Bore da pawb, bore da, croeso cyfarfod bwriad eich cyhoeddus Cymru. Heddiw, y bore yma, mae'n gyffroes iawn i ddweud croeso cynnes y bwrdd chwaraeon Cymru hefyd. Mae'n fel y hen amserau I fi. I've been on the board of Sport Wales, so it just feels like old times that I've got them here. So it's really, really nice to have you attending our board meeting today, and welcome to everybody else. And Tani, we have Tani Gray-Thompson, who's chair of Sport Wales. And Tani, would you like to introduce the people that you've brought with you today?
Yeah, thank you. And Pippa, and thank you to the rest of the board for inviting us here today. It's really exciting to be here. Should we just do your own introductions? Because
yes, boss.
Thank you.
Good morning, all. Craig Williams, I'm the director at Sport Wales.
Hi, Dr. Alison Parkin. I've just joined the board of Sport Wales. I'm a newbie. I'm very excited.
Morning, everyone. My name is Jess Williams. I'm the head of service partner development, and I look after a bit of health and education work. So really great to be here. Thank you for having me.
We've brought some copies of our manifesto, which we're not calling a manifesto anymore. It's a policy position, so we thought that might be useful. But we're really excited about the work that we can do with Public Health Wales, just in terms of the lens it brings to our work. And actually, we're trying to do so much of the same thing in terms of getting a fitter and healthier nation. So it's a really exciting time for us. So thank you.
Yeah, no, it's brilliant, and I'm really glad that we're able to work together and that you've been able to come today. And obviously, we've got a presentation a bit later in the agenda. So I'll get everybody when they first speak to introduce themselves, and that way then you hopefully get a flavour of who's around the table. It's quite a big room here today. So just to let everybody know that the meeting is being live streamed, and also that the meeting will be recorded. It's only for the minutes, and once the minutes have been done, the recording is deleted. We've got apologies for absence from Neil today. I don't think we've had any other apologies. And welcome to Liam, our aspiring, from the Welsh Government aspiring board members scheme. Very nice to see you again. And I think Sharon is going to be joining us later on for the screening. And finally, last but not least, I'd like to introduce Catherine, who is our newest board member. It's her first board meeting today. I'm sure you're all going to make her feel very welcome. I know that she has met a few people, but hopefully she'll catch up with all of you in time. Ian is going to be attending as well via Teams. So nice to see you, and Claire as well. Welcome online. So just to check, are there any declarations of interest or anything on the agenda today? Lots of shaking of heads. So without further ado, I think we're going to move straight on to Sport Wales. And I'll start off actually, Jim, if I can come to you, just to tell us a bit about the kind of working relationship.
So thank you, Jim. Jim managed to give on the kind of like for the I'm Jim McManus, I'm the National Director of Health and Wellbeing. I've been really grateful actually for a partnership, because we know that if physical activity could be put into pills, it would be a massive benefit for everybody's health, not just in terms of cure, but in terms of prevention and in terms of management. You know, we know that physical activity is actually better for you for some common mental health issues than medication. And I think we perhaps as an organisation have not joined up well enough with Sport Wales partners in the past. And so the process and the amount of work put into it by Sport Wales colleagues, but also by Paul Pilkington and John Bradley, my director, has created a document that I think builds on our strengths. It's very focused on action. We've already got work going on with Sport Wales colleagues. it focuses on how we can use our networks to bring Sport Wales colleagues into venues where we are, and vice versa. Yesterday, thanks to Claire, we had a really good event with WCBA, who are also working very closely with Sport Wales, and a piece of work has already started about young people and volunteering, thanks to Claire, which is actually about synergies. And the benefit of this agreement is it doesn't create extra work. It's about doing what we do better and differently and smarter and in a more joined up way. My ambition is to get Wales moving. And I remember while I was rehabilitating my knee after, that lovely injury that I would like to say was weightlifting, which was actually carrying a suitcase upstairs in the building. There is a wheelchair accessible walking trail around bits of Eryri. And I was so impressed by this that I think Wales has got so many things to offer. So for me, we have not got tied down in the semantics of what's the difference between sport and physical activity. It's just, can we just get people shifting a bit? Because I think that's a nice debate for public health when it's being purist, and we can't afford to be purist. And we've already got the work on the research of summarising that going on. So I couldn't be more happy after perhaps a slow start. And I think we need to bring people on board who have moved to a more pragmatic approach, which I think is being brought by Sport Wales colleagues. And I know that Owen isn't here today, but he's one of the Sport Wales team that are doing. But Graham and Jessica sat and wrote principles into the partnership agreement and improved it enormously. So I'm delighted and really proud of the work that I've seen people do on this, and particularly for speaking for so long.
Thank you, Jim. And Tanya and I have had plenty of conversations about how we can take this forward at a board level, an operational level, and also for us as an individual level as chairs as well, and how we can start talking to other people across other sectors in Wales. So I'm going to hand over to Sport Wales.
Thank you very much. And just want to, endorse what Jim said, in terms of there's so much work that's gone into getting to this point. And it's how we get to different people. So, through the work that you do, you'll be reaching different audiences from the ones that we're able to reach. And I think, if I could wave a magic wand, I'd probably call us Sport Physical Activity Wales, but that'll take any arguments to try and do it. But I think actually all the team understand it's not just sport for sport's sake, although, we do spend a lot of time, thinking about Commonwealth Games and sort of competition. But actually it's about the health and fitness and developing this lifelong love of activity and understanding that people, dip in and out and might go to lots of different sports and might do it in lots of different ways. But actually the bottom line is we need a fitter and healthier nation, and however we can get to those people, we need to find a way of doing that. And I think it's also recognising we can't do everything on our own. And I spent a lot of time talking about joined up government. So this is a really important step forward for us to be able to kind of have that sort of discussion. I don't know, Graham, if you want to pick anything up on sort of how we've got to this point from our point of view.
Yeah, indeed. And Jim, thank you to you and your colleagues, Pippa. It's nice to see you in a different environment, I suppose. It's always good to work with you. And Tracy, we've always had a really good and close relationship, and we've worked on a number of initiatives together that have always been productive. I think what this agreement allows us to do is probably just lift that a level and think more strategically. And you're right, Jim, it's not about necessarily doing a lot more, but it is about thinking smarter. And what really buoys me, we've been working with some of your colleagues, Paul and John, particularly around how can we support young people normalise activity into their daily lives. And the passion that everybody has for that is tremendous. So it's not a discussion about should we or shouldn't we be working together on these things. It's a really passionate discussion about, well, how can we make it the best it can be? And that, I think, it really augurs well for how we think about the partnerships moving forward. Very early on in our conversations, we shared with you some thoughts we had around some of our policy aspirations, and they really chimed in, didn't they, with where you're coming from. And to reiterate what Tanny has said around, you know, we want people moving more, sitting less, and if that's through any form of physical activity, that's really good for us. You know, we are not specialists in a pure sports sense. Of course, we do that. That's part of our remit as well. But actually, when we get the nation moving, and we see many benefits, not just and really beyond the physical benefits, because I think they're well known. I think we're starting to much better understand the mental and well-being benefits of being active, and I think we're starting to understand how being active gives resilience to young people and some of the challenges that they face, and also how it can strengthen community cohesion. And I think collectively with the networks that we're developing, and it's I think an interesting ongoing conversation here, particularly about our local networks, how we can make sure that, you know, we're quite removed, aren't we, from people and communities, but how can we get our local teams working together to really support place-based activity? I'll pause there if that's okay. Jess, I don't know if you want to just touch on some of the work we've been doing around mental health and well-being. So I think that would be really interesting to share.
Yeah, really happy to. I think that's a really good example. So I think from my perspective, you know, a lot's been covered there in some comments, but it will be really normal and very natural for us as two organisations to have slightly different remits and priorities and a slightly different conceptual way of going about our work, I think. But what's really important and has been highlighted is that intersect in the middle. So where is the common ground in terms of the things that we care about, and how do we leverage our own networks and I guess our own stakeholders to make that happen? There are a number of bits of project and strategic work that are going on between the two organisations at the moment, one of which I think there's a real synergy in our approach to supporting mental health and wellbeing for young people. And I was really enthused that the statement that, you know, Public Health Wales have recently produced, which talks about those protective factors for young people across this agenda, really chime with a lot of the approach that we've taken with some of our funded organisations. So I think in that statement, you know, we talk about the sense of belonging and connectedness, the sense of activity, the importance of nature. And those are conversations that we're having with sports organisations around how do you create environments, particularly for young people, that do all of those things. So for me, you know, that's just a really good example of slightly different approaches as organisations, but there's a lot of common ground. And I think, you know, the work that we've already started across some of the work we're going to look to do in schools around what does good quality provision of physical activity and mental health and wellbeing in schools look like as a collective piece of work. It's really exciting. So yeah, really grateful for the work that's happened from Public Health Wales as well. And you know, it's been a real pleasure and a really exciting thing to work at, because I think there's learning for the two organisations as well.
Yeah, and I think we have quite a lot of contact into schools. We know that, don't we, with the number of schools that we have signed up.
Yep, we've only got one secondary school not signed up now, and that's come out of special measures, so they're getting a visit from me. I don't know if you deserve that. But you know, the public health impact of what Sport Wales does hits you in the face. And if we can get that into every school in Wales, we're laughing.
Yeah, so that's something that we can collectively work together. And we all know if we can produce a whole generation of healthy children, we'll produce a whole generation of healthy adults. So has anybody got any questions or comments on this? Tracy?
Yeah, just to say, you know, Dr. Val, it's fantastic to have you here. And just before, just some reflection, to say big thanks to Pippa and Tanny, because you know you've helped really drive, as Graham was saying, us to a next level of the relationship. So thank you very much. And you know, you both of you as amazing role models, and all of your achievements. You know, we really benefit from both of you in this relationship. So thank you both. I think it's really exciting. You're right, Graham. We work so closely, sometimes on strange activities that we've been asked out of our control from an organisation that we remain nameless. But on the whole, really strong relationships. And now our combined networks how we can take a life course approach to this, because it is all about, you know, health and well-being, isn't it? Whether that's mental or physical health and well-being. And for me, the passion about mobilising our young people, you've got such a fantastic young ambassadors program. You know, we have, and we're just refreshing that. So how we can mobilise both of our networks for young people is really key. And I guess the final thing for me is we've been spending quite a lot of our time over the last 10 months or so just positioning what are the kind of 5 really key public health messages to influence manifestos and a potential future programme for government that meet the needs of the population challenges today, but also for the future. And so, you know, if you could only focus on 5 things, what would they be? So I just wonder offline, Jim and Samina, whether we can connect with you to see if we can do a little bit of a pincer movement to give effect to your views and our views as well. But really excited, and it's please help us out to the mince pies.
Yeah, and maybe that's something actually that we could perhaps come up with a little bit of a communications thing that would be quite nice. And I know that there's because I've read your not manifesto, and I know that there's a lot in there that actually really links up with us as well. And so I'm sure everybody really happy to read that. Tamsin, I'll come to you first, and then Jim, if that's okay.
Thanks for introducing yourself. My name is Tamsin. I'm Associate Equality Diversity Non-Executive Director. One of the things that strikes me often about when people active is the infrastructure or the lack of infrastructure across Wales. I work in lots of communities, and I know that a lot of communities really struggle for places to hold sports activities. And I think it also comes into sharp focus as well when you've been on the continent and you go to Spain or France, and every village is they've got amazing village infrastructure around sports, 5 different courts, public swimming pool. But what I'm interested in, and I know the new model, especially in Cardiff, is that we build these fantastic new sports facilities around 21st century schools, and then a lot of the time the community is locked out of those facilities, or they're particularly expensive, which doesn't allow the young people in particular to use those facilities. I was just wondering, is there any thinking around, you know, what we're doing around creating access for sports and infrastructure? I can't think of infrastructure, but I'm sure you understand what I mean. Just like kind of spaces where you can play sports.
That specific point in and around school, I think that there are 2 current things that are in train that are seeking to address that, because I do agree with you that sometimes there are kind of great community facilities that are not just open and accessible, or there aren't any. But we do work closely with the education team, community focus schools team, to ensure that if there's any sporting element to any school development, that we get early sight on that. So we do influence the type of design, but that's been limited in terms of access. But one of the projects that we're working with Jim's colleagues on, which is around, we called it daily active, so young people being active on a daily basis. One of the domains is about community access into that school hub. So providing them with the right resource, information that means it can be accessible and make it easy for schools. I think there is this cost challenge that we really need to look at in various communities. So across the pieces, looking at, you know, well, is there equal access as part of that work, but really trying to provide the right resource for schools to enable them. And there are some fantastic examples. We did some pilot work, and I'll report in a moment, conscious of any of the other questions, active education beyond the school day, how we can really utilise activity after the normal school day to get young people engaged in school and come to school more often. And there's some really great examples of schools that have managed to do it. I think there needs to be a greater sharing of that. What arguably is really, really good practice that could be locally applied. But that initiative that we are working on, and we're still pushing government hard for some funding to allow us to move this from quite a small scale conceptual approach to what that prize forward delivery should give us the opportunity to start addressing some of those challenges. Apologies for how long it's taken to respond.
No, I'm interested.
It's such an important aspect. I think a lot of the equality issues can be overcome in a school setting if you approach it, whereas in a community setting, I think sometimes inequalities are just further exacerbated, whereas within the school, I do think they have the opportunity to ensure all children have the right, appropriate activity opportunities.
And our capital budget is relatively small in terms of, you know, we could be given 20 times the amount and we still need more. So actually, and because data is gathered differently, which is a bit of a pain, but, you know, in England, you know, it's a huge percentage of facilities are locked behind school gates, which is always quite surprising. And it's how you open those gates, you know, it's actually, people and I was just chatting briefly before, you know, about new housing developments where things built. So what we're trying to move away is not talk about PE lesson, because that's getting strong, you know, and actually you're not going to fix up in 2 35-minute lessons a week. It's actually the whole school day is really important, you know, but then that gets us into talk about active travel and bike lanes and actually just having somewhere where you can lock your bike at the school. Again, there's really good data from England about they've removed bike sheds from schools. So children don't go to school on the bike because they can't lock the bike. I mean, it's some really simple stuff can make a big difference. And so just really briefly, and this before I joined the board, we moved to sport partnerships. So actually having better local connections, because sitting in the office in Cardiff, we can't know every single bit of work that's happening in different parts of Wales. So sport partnerships that we can send you more information on that. I think are really important for having a different type of connection.
And it's about it is about how we influence in that space, because that's really what we can do here is we can try and influence whilst also kind of finding out, working on what's happening in schools, on the ground, in clubs, within the sports partnerships, for example. I've got a whole bunch of people I think who want to speak. Jim, I'm going to go to you first.
Thank you, Chair. Just to build on what colleagues were saying, there is, that's the public health approach in action, but there is a whole school day collaborative going on, led by the Cabinet Secretary, where I've been trying to get an improvement approach to health in the whole school day. And one of the things, we've got mental health and we've got directors of education, we've got STIN joining now. And one of the things I want to do is make it not just about mental health and attendance, but make it about activity. So my ambition is to get sport groups colleagues into that program as well, so that we're directly talking to the Cabinet Secretary about this daily active stuff. But the point I was originally going to make was that sport groups colleagues have gone out of their way to listen to our policy messages as we've been developing them, and share us theirs as they've been developing their manifesto. And if you can read, if you read their manifesto, which you've got copies of, you will see actually a lot of our stuff is very clearly incorporated in there. And I think that's an early success because we're both sending similar messages to government using slightly different language, which is helpful. And I think I nipped in front of Clip, so I do apologise.
Angela.
Yeah, thank you. Angela Williams, I'm the Deputy Director at the minute. I'm the Director of Operations and Finance within Public Health Wales. Thank you for your presentation as well today. My comment was around how do we make sure that we are reaching those deprived areas and giving what we need to give in a way that suits those local communities. So I'm quite passionate about this because I don't think that I come from a deprived area in my mind, but I do. So all of my community is centred around the activities around rugby and football and what that means for longer term, health when you grow up in that environment. So is there more that we could be doing which is tailored to support the young people who maybe come through that, sort of stream? I think we're passionate about that because some of the children in my community, don't have any other form of exercise other than coming to the local grassroots rugby. And I know you work for WI, so you probably would have. And with over 200 children coming through all age ranges of our rugby team, I speak about this because my family's fully, sort of embedded in that. My brother's a coach, and we support these youngsters with tog sharing. When people grow a little bit big for their togs, we pass them on. Men, that I do this maths tutoring for over 200 of these children. When they turn up, they have like a bit of tea, they have a bit of supper. We do this sort of maths tutoring, so it's all about their health well-being from a very early age. So yeah, that's sort of how do we do more, which is tailored to support the communities that we serve.
I think the world of sports changed a lot since I was in school, where girls were off hockey and boys were rugby, and not maybe a bit of netball, and that was it. So our funding models changed quite a lot in terms of we're now the second, I think, biggest school sports survey in the world, aren't we? I think we were number one until England decided to do one, which is a bit annoying. But actually, we asked them what they want to do, because actually, not every child puts whatever sport it is. They might have quite a big difference in terms of what they want to do, and I think it's quite important to ask them. That survey, I think we're going to look at, because I think there can be an element of how do you know what you might want to do if you haven't seen all the different sports. So how do you know if you want to do bouldering if you haven't seen bouldering? But actually, some of it is based on what's in the local area, and I think that's really important that we're actually asking people, but giving opportunities to everyone. I think this is beyond, it's probably more of a UK issue than Sport Wales, but cost of performance pathway is just going up and up. And it's actually outside of a lot of families' reach. So the average cost of performance pathway now, if you're going to play sport seriously, is 12,000 a year for a 14-year-old. So we've moved away from medals. Our views, if we produce well-rounded athletes, if Wales produces well-rounded athletes, the medals look after themselves. But I think there's something that we actually need to be looking at a UK level in terms of, coming back to, and this is when what Sport Wales does, I think it's amazing, is around that fit and healthy child, and the performance pathway can sort of look after itself. But yeah, we need to have more sports on sort of show for young people to play. And I think again with the governing bodies and the partners we support, they are, we're very clear with them what we expect from them in terms of participation numbers and who they get to.
Yeah, I think it's just one thing I'd add to that, because I think you're absolutely right, Tanny. And so I think this what you've highlighted really highlights the importance of the school and the school environment and the role that can play. But from our perspective, a number of years ago, and people will remember this, we changed the way in which we invested in partners. So we invest in a group of partners or organisations that are governing bodies of sport, like our friends at WIU, etc. But we also have a slightly different model, which takes a principle-driven approach. And what we look at through that funding model are who are the organisations that essentially work in spaces or do provide offers that are not traditional sports, but they look at offers that are doorstep sports, or they take a real asset-based community development approach to what they do, or they're offering in non-traditional sport spaces. So we've got a separate investment stream that really looks at who else can we work with within the system that isn't a traditional organisation, which actually isn't going to capture some people, as you described, Angela. I think if I was to try and think about the opportunity that exists between our two organisations in that space, it's certainly something about asset-based community development, and how do we understand what is happening throughout Wales in different regions and accelerate that really, really good stuff. Your story is a really great example of how communities come together. There's something about food in there, there's something about education, there's something about the sense of being connected, and this sport and physical activity. And how do we think differently, I suppose, about some of those organisations that we can support? If there's a shared opportunity there and organisations that could deliver, or programmes that are working really well from a children and family perspective, how do we amplify that and think differently about that could be a direction for two organisations to sort of support? I think the data and, the kind of traditional sport offers are certainly still really valid. And for a lot of people, that is still the most brilliant offer they'll access. But when we're talking about kind of connecting a community, there might be something different that we can explore.
It's absolutely true. Liam, was there anything that you wanted to add?
No, it was in mind, the idea that just talking about those economic groups. And I think, I welcome the comments made by everyone here, because essentially a lot of organisations are doing lots of pockets of food and fun, fit, veg, fun, lots of provisions tagged in those economic groups, street games and that. And I suppose the question is, how do we see that coordination between separate organisations of aligning it slightly better? Because I think there's only 3.2 million people in Wales, and everyone's guilty of harbouring their own ideas on what they want to do from a partnership perspective. The Welsh Local Government Agency partner with a lot of organisations separately. Street games are coordinating in that area. There's other charities. So do you see that as the role as the localised partnerships, or do you see that more from a national oversight? Was the question.
Personal view, and they get different views. Actually, I think it needs to be locally led. I think if there's support needed to facilitate it, then others can help. But it needs to come from the place up, in my opinion.
I think there is something, isn't there, about joining up organisations though from the top as well, because I think you do need people in their local communities to be working together. But there's also something about, exactly as you described, where people hold things close to their chests, as it were. I think sometimes that's because they don't have these kinds of conversations where people understand what their collective feelings and work can be to influence what goes on in the ground. So I think we need to look at it from both ends. I think that would be my personal view. And it's interesting you said everybody have a personal view. Kate, I'm going to come to you. I've got a long list of people here.
Thanks, but it just proves how interesting the conversation is. Good morning, everybody. I'm Kate Young. I'm the non-exec director on the board with the third sector specialist hat. Couple of things really. I would kind of argue the point that sport decisions, choices have changed a bit in school, because my son is currently going through school and he's a dancer, and he's endlessly told he has to play football and rugby and he can't do dance in school. And that is a thing. But you're absolutely right, costs a fortune, because it costs us £400 a month for him to be a dancer, because that's what he wants to become and train as a professional dancer. But he is one of two boys in his region, and that partly is because every time they try and explore it in their community or at school, it's a bit like, why don't you play rugby or football or something, because that's what the boys do. So I still think that's a thing, if I'm honest. So I don't know. We're cracking at it. I recognise we're cracking at it, but I'm not sure it's that. He did manage to push to actually teach all in Key Stage. He decided his way of getting around it was to get to the teachers, and as Strictly is on. And then on Friday morning, he's teaching all the teachers in his Key Stage cha-cha to actually make them interested, so that he can dance, to then enable him to do dancing with the girls in school. It's one heck of a backward way round to get round to being able to do it. But that's a sort of separate thing. But I suppose in terms of the building on the conversation about community asset and things and the joining up, there's a lot of evidence, isn't there, in the community about what works well for young people. And I'm thinking to myself, there are some fabulous big third sector organisations. I mean, Scouts, for example, they got the Welsh Charity Award this year for the most influential organisation. And they're doing some incredible things, aren't they, with young people and encouraging them to enjoy outdoors. Your point, funny, about trying different things. That young people in that space go, oh, I've never had a go at this and I've never tried that. And so I think there's definitely something about those local groups, but the point you just made, Pippa, about actually maybe starting off with some key conversations with some of the bigger community-led organisations where we could sort of say, is there something more we could be doing, just building on your point about, how are we all working together and funding? I think that's definitely something. And from the school's perspective, one other thing I've noticed, particularly because I'm also a PTA parent, we've all been through those, the joys of being a parent-teacher association parent. But the trips to places like Story Arms and Grannog, our outward bound adventure spaces, we're finding more and more
that the money that's raised in community schools is actually having to go to underpin and supplement children so they can access some of these things because they can't afford it. And there's a conversation in that space as well, I think, about when we are offering opportunity, what's happening with the funding to enable young people to be able to take those opportunities, because it's falling more and more on volunteering and fundraising for other families to support other families to join into those things. So there's something in that in our messaging, I think, to government as well, and in part this joined up working. And then the last thing I was going to say with WCDA is they've just launched the barometer thing, which is the sort of temperature check for the sector. And actually it'd be really interesting to have a chat, I think, with the senior team WCDA about, well, what's the temperature check then for those kind of groups that are doing stuff that you were saying, which aren't necessarily conventionally known as sport groups, but they will be doing things like wellbeing walks or activities and things. And are we losing them more than others potentially? Because they're often the smaller ones that are grassroots led, as we've said. So that would be interesting, I think, is a bit of data to track alongside.
Yeah, I do think that will be useful data, I think, to both of our organisations, and it's going to be quarterly as well, which I think is really quite remarkable. So give us an idea to track, option to track trends. So yes, I've been keeping my eye on barometer. I think it sounds very exciting. Samina, I'm going to go to you.
Thank you. So Samina is our National Director of Policy and International. Lovely to meet you. I've been looking at the manifesto position statements, and I think it's just really good to see two organisations with complementary messages. So I think I'd really welcome that ongoing conversation, because there's real opportunity here. And in terms of our messaging, it's very much in the prevention space, as you'd expect. And you know, a lot of our work and the policy messages are about healthy places. They're also about protecting people from climate change, and this all links into physical activity and active travel. There's also a few opportunities, I think, for us in terms of wider collaborations. So, you know, I just thought I'd briefly mention it, if that's all right. So I was thinking about international learning, because Tanya, you mentioned understanding what's happening in the world. And I think, you know, that'd be something that would be good to touch base on. So we work with other European and worldwide public health agencies and organisations like WHO. We also do international horizons, so we'd be very happy to have a conversation about what would be helpful. The other thing that was mentioned was about understanding public views. So we do a regular survey of adults in Wales, and it's an opportunity to understand behaviours, views, and understanding of what matters to them. So there's an opportunity there, you know, if you wish, to kind of tap into that moving forward. So pretty welcome opportunities.
I've still got a couple more people who want to speak. I know that we're already running over time a little bit, but it's because it's such interesting stuff. Meng, I'm going to go to you and then Sean.
Thank you. Meng Dewey, co-founder for Medical and the medical director for Public Health. Really great to hear what you had to say, and I reflect many years ago when I went to school. I was taken by my father, went to the headmaster's room, and he said, "Oh, you'll be playing rugby soon." I was 14 years old with thick rimmed glasses, and in those days it was actually glass. And he looked at me and knew that I wasn't going to be playing rugby because I was dependent on my glasses. So I ended up being in the non-team. So my point is, and it took me about 30 years to actually recover from that label, to then be serious about physical activity. So my point is, have we got the language of participation right?
Oh, I could spend quite a long time talking about that. I think it can be quite variable. So, you know, I sort of briefly mentioned, you know, medals, and, you know, at UK level, there's an obsession with medals. Bit rich. Different night talking about that, seems to be GB, but it's what drives those medals. And I think, you know, you can be quite damaging to children at a young age saying if you're good at sport or you're not good at sport, and some of the talent pathways, sports like football will tell a child at 15 or even 14, yeah, good, and don't think about how you recycle those young people and get them. So that's why that kind of love of physical activity is really important. And understanding that, if there's one thing I could change on, if we're thinking about sport pathway, is actually just giving children more time to develop. Most sports at UK level have some very arbitrary cut-off age group where they decide at 16 whether you're good or not. And I think I'm influenced by that, because if I existed in the system now, I wouldn't make GB, because I only really developed when I was 18, 19, not when I was 16. So, some of it's around, actually comes back to the experience in school, how the teachers do it, how they select, what sports and activities are offered. And that's something some of, our partner work in is really important as well. It's not sport for sport's sake, it's wide man. And sport for sport's sake still matters. But if you ask anybody in the street how many medals GB won at the last Olympics and Paralympics, 99% people wouldn't know. They'll remember moments. And it's those moments that are really important to connect.
Yeah, I think there's a lot more to be done around language and messaging. If you look at influence, those that influence young people, that be teachers more generally, so it's not their fault. I think that through teacher education training, there was not enough emphasis around active health and well-being is. So we address some of that. And I think the other big area is about parent expectation. Might not have been an issue in your particular circumstance, but parents living their own dreams through their children isn't real. So it's all about winning. It's all about to the next level of competition. And actually, we want young people to enjoy it, and we want them to find something that they enjoy right now. And it might change. And as long as they're having fun, doesn't matter what they to do with it, being active. We're agnostic about any particular activity, but sometimes that's not reinforced through messages of parents and being a parent. I sometimes can remember when I've maybe said the wrong thing as well. So there's a lot more to be done, but it's probably a topic of conversation in its own right, actually.
I'll just pick up really quickly. My daughter's been in year 2, and she didn't win the dressing up race. And another parent came up to me and said, "You must be devastated." What was happening with that phone? And I thought, she didn't win. Like, no, okay. And then I thought he was taking to Nick, and he apparently wasn't. And he went, how are you going to cope? And I sort of, at that point, still thought he was joking. And I went back and said, "Oh my God, yeah, I'm just devastated because I've got this campaign for the next 20 years to get the dressing up race in the Olympics." And, I'm hoping. And then I realised it was like, "Oh no, you're serious." But yeah, I mean, there's some stuff around, just expectation, yeah, and the fun bit's got to be part of it.
Yeah, I think I'd like to see that in the Olympics. Just very briefly on teacher training, I think there is probably something more we can do around getting more teachers understanding physical activity, but also giving them a greater awareness of the kind of equality issues as well, and to be able to treat children more equitably, so that because we know for disabled children, for example, that they are less able, have less opportunities to get involved in sport and physical activity. So that's something that we can influence through teacher training. Maybe that's something else we could work together on. I'm going to go to you, Michelle, for the last word.
I'm showing this nothing else than non-exec. I'm very enthused by all the conversation, and I think there are huge opportunities. I just wonder if we're maximising the opportunities at a sort of policy level to amplify health and sport together. So just a thought about the badging, not just which would enhance community working together. Thought. I wondered if you had any asks of us as a board, and I just wanted to amplify Kate's message about dance. I have a ballerina granddaughter who's constantly told she's not doing sport when she is doing a huge amount of dancing. So I think there are messaging about different ways of being healthy and well-being through exercise, that you can badge things to lunch. So I very much support your grandson, by the way. Your son, my grandson.
And found it's a really great question actually, because I think it's what we've been, it's one of the things that we've been talking about, that Tanya and I have been talking about, is how do we talk about policy and working with more partners than just Sport Wales, so that we can actually build some of this health benefits of sport, physical activity, movement, whatever it is, into sort of the fabric of everyday life, whether we're talking about, you know, housing developments or whether we're talking about schools, or so there's a whole load of stuff. So we kind of feel like we're at the start of a bit of a journey. I know that we've had this partnership agreement now signed between our executive teams, which is absolutely fantastic. But I can tell by the level of conversation in the room that everybody's really enthusiastic about it, and it's fantastic. I think that we are now, you know, moving forward with this. So was there anything, Tanny, that you wanted to just close the conversation off with?
No, thank you. I'm just look forward to working with you on multiple levels going forward, because you know we're all aiming for the same thing, and it's just a brilliant opportunity. So thank you. And we'd like to invite you to one of our board meetings.
I'm sure we'd love to come, and
there's a high bar on the cakes and
yes, I have to say that you know, some of the biscuits that Sport Wales provides are very good. So thank you very much for coming today. I'd like to invite you to stay to listen to the Chief Exec's report, so that you can just get a bit of an overview of what's going on within our organisation, and then we'll take a short break after that.
Yeah, and I won't be offended if you have to be.
Yes, I'm really very sorry.
You know, not at all.
That's just lovely to see you all.
Nice to see you. Thank you. So, dear Pippa, we have quite an eclectic report this month. There's a lot going on. So, as usual, I'll take it as read, but I will bring colleagues in on particular items. So, we'll start with exercise Pegasus, that colleagues in Sport Wales probably, fortunately, are less familiar with, but we've been living and breathing it for a couple of months now. But I'll ask Meg just to do a small summary of our involvement. Thanks, Meg.
So Exercise Pegasus was a UK-wide tier 1 level exercise that brought together our response partners to an imaginary and worked up scenario involving a novel pathogen. In this case, it was enterovirus, the family of viruses that causes polio. And it was held over 2 months and divided into 3 distinct phases: the emergence phase, the containment phase, and the mitigation phase, with the promise of a recovery phase next year. And in that period, we stood up a response within Public Health Wales and worked with our national partners and our local partners to test our arrangements. And actually, they worked very well. Some new arrangements were put in place on the back of the learning from the COVID inquiry so far. And the experience actually brought together our staff to test our responses to this novel pathogen. And I think on the back of that, I've got a stronger assurance about the organisation's capabilities and capacities to respond to a future pandemic. There's a formal 4 nations learning debrief on the 9th of December, which I and other colleagues, including the Welsh Government, will be attending.
Thanks, Nick. Pippa, should we just carry on through and then pick up the questions? But to give an idea, over 140 of our staff were involved in the exercise at various times. So it was massive for all public health bodies and other partners. So the next 2 items I want to draw your attention to relate to the pandemic and to the public inquiry. So the first is item 3. So big thanks to Meg and our colleague Chris Williams. Join me in the joyous pleasure of attending the Public Accounts and Public Administration Senedd Committee on 12th of November. So this was to give evidence in relation to the Module 1, the COVID UK Public Inquiry, which is around pandemic preparedness. And some time ago, the government established a Senedd committee, which was a special purpose committee, to look at the gaps module report from the public inquiry by report to see gaps consultation, what are the gaps in Wales, and then bring people in to give evidence. So that's what the spirit of that was. The Special Purpose Committee was stood down and the Public Accounts Committee was given this role. So we were in there for a couple of hours and we just asked questions around the module report in relation to pandemic preparedness, where we were at now, Pegasus. So it was actually a constructive conversation. The intention is, pending a change of government or new government or post-election next year, that this will take place after every report. There'll be 10 reports and there are 2 down now. We'll come to second in a minute. So we don't know what's going to happen with that. So obviously we have to look forward to this for many, many years to come as an experience. So I'm going to move us then on to the second item in relation to the public inquiry, and just to give a specific update in relation to the publication of the Module 2 report, which is a combined report looking at government decision making within the UK government, Scotland, Wales and Northern Ireland, which was published last week. And I'm going to ask Paul to give an update on findings of that, and then May just to respond to how we'll be taking that forward as an organisation. So
thank you, Tracy. I'm Paul Basie, I'm the Board Secretary here at Public Health Wales. Yeah, so just to give you a brief update on the report. So the report was published last Thursday. It's an 800-page report, split over 2 volumes, which makes 19 substantive recommendations at the end to improve government decision-making across the piece. So the report very much recognised the advisory role that Public Health Wales had in the system, and also drew out the benefit of early public health advice to government decision-making in a pandemic response scenario. In terms of the recommendations, we're still organisationally digesting those recommendations and the full content of the report, and reflecting on what we can do to improve our emergency resilience, preparedness and response arrangements further in respect of them. But essentially the recommendations focused on a coordinated approach for pandemic management in the early stages, recognising the key role of COBRA at that time, and that the right individuals from the right devolved organisations and administrations are present from the very off. It drew out the importance of SAGE as a source of data, the importance of sharing that data widely and having the right people invited to the right meetings at the right times as the pandemic starts. In terms of preparation for the future, there are recommendations around a body of experts on hand, ready to assist should a pandemic come again, and also the need for us to risk assess and put frameworks in place to understand what new pathogens could look like, and in particular how they could impact those inequalities that we have in our community, and how we can see those down the line. In terms of the legislative layout in Wales, the governance and the government of Wales was recognised as having a good governance framework in place, and the powers, responsibility and roles were recognised as being in place in Wales, with other recommendations being made for Northern Ireland specifically to strengthen their approach as well. So a lot more to come, a lot of learning and digesting to do, and as is our process, we hand over to Meg and his team to study those recommendations and work out how they apply to us. So at that point, I'll hand over to Meg.
So thank you. I've read a fraction of the report. I won't tell you what but it covers a whole range of things. And in any emergency response, no single entity is in Ireland. We have to work together. We have to collaborate at every level. So where there are recommendations around scientific and technical advice, as the National Public Health Organisation, we provide that expertise, and we had done so during the COVID pandemic. And we put in a system for that advice to be commissioned formally, and that has worked. And actually, Exercise Pegasus has brought that system out, and we applied it to effect. There are also recommendations around addressing vulnerabilities and inequalities. And again, we have started out thinking about how we are on the front foot when dealing with inequalities, and are putting in place some resource to look at building community resilience so that the differential impact of any threat to health is managed in the preparedness phase rather than during response. The recommendations are largely around UK government and devolved administrations, but we will play a part. in supporting that. And we will look at how we can support the public health communications and also the laying down of legislation as well. So we'll continue to look at the recommendations and understand how Public Health Wales will respond.
Thank you both. Just a couple of final items just to refer to. Item 6, our Welsh Public Health Conference. So before COVID, we used to run 2 days for Welsh Public Health Conference, not a Public Health Wales conference, a Welsh Public Health Conference with over 500 people. So we brought that back after 6 years, and so that took place in November. And I have to say it was a fantastic event. Not that I'm biased, but we had over 400 people from all parts of society. We had the Minister for Mental Health and Wellbeing, Sarah Murphy, spoke really well. We had Monica Kaczynska, who's a WHO leader, who also spoke very well. And we had a fantastic opening by a renowned poet, Duke Al, and artist, Don Zoy. So it was a really great set-up day. And just to say a really big thank you to our comms team, particularly Leah, Laura and Danny, and everybody who was involved, because it was just really nice to get the broader partners, and I think we had a couple of Sport Wales colleagues who joined us as well. And then the final item on the report, but I also just want to update something with Selina that's happened since I wrote this report. Just a really big shout out to our team who won the Silver Award for the Stakeholder Community Relations in the CIPR Awards for our Tackling Diabetes Together hackathon. So I just wondered, Jim, if you wanted to just say 1 minute on that.
Thank you. Yeah, so basically this was Leo's team and comms team who's timed the Tackling Diabetes programme together with BIES, who created this, brought 60 people across Wales with diabetes together for a day with clinicians and actually with some poets and musicians. And we actually talked about their experience. Out of it has come new patient engagement on our stakeholder board, the launch of 3 apps in Wales for people living with diabetes, work on a point of diagnosis pack, and this, the award for the work that they did. So it's had a massive impact. A couple of clinicians said, quote, it was a bit cringeworthy. The patients loved it. One person came all the way from Haverfordwest to participate and tell their experience of how bad the journey is. So this is about patients, people living with diabetes, improving our outcomes. And to be honest, I think it's the best event of the year. I was out there for the day. It was fun.
Thank you, Jim. It's so key, isn't it, to have the voice of people who've lived experience in everything we do. And then finally, something that, as I say, isn't in the report, just asked Samina just to give an update around health impact assessment regulations that were passed recently in the Senate. So
Thank you, Tracy. So if we think back to 2017, we have the Public Health Wales Act, which made provision for ministers to publish health impact assessment regulations. A few years later, they were laid before the Senedd and passed last week, which is fantastic. And the CAPSEC actually said that this was a real opportunity to embed health equity at the heart of decision making. So that's the intent of it. So public bodies will be required to do health impact assessments as part of strategic decisions. So very much our work here. And Public Health Wales has a duty within the regulations to support and advise public bodies. And part of that is providing statutory guidance. We have a joint project board with Welsh Government at the moment about how we deliver that. The regulations don't actually come into force until 2027. So as part of the process, we do have a board development session in train to have further conversations and get your views and advice.
Thank you, Samina.
Over to you, Kevin. Any questions or anything for Tracy on anything in the report, Tamsin?
Just a quick question on the health impact assessment. Maybe we'll flesh out in development. I was just wondering, with the needs to do inequalities impact assessment and now the requirements to the health, there's an element of equalities in the, if I'm correct, I think I've seen there's an element of equalities in the health. Is there any way of kind of collapsing the two, or instead of having 2 separate assessments, like, that we can think through combination approach?
It's a really good question and something that I think we definitely would cover at the development session. because building in our impact assessments into our papers generally is something that should sit at the heart of the decisions that we make anyway. So I think that is definitely something that will come out of board development. Sorry, Samina, I stole your
No, not at all. That's absolutely similar conversation that's ongoing, because we also have the socio-economic duties. So there's multiple things here. And health impact assessment is population level, looks at specific population groups. So in terms of equalities as well. And it also looks at wider determinants. So I think there's an opportunity to think holistically there. I completely agree. It doesn't benefit anybody to have multiple assessments that then don't add value. So the key is to how we connect it all. But I think that's part of our conversation, but it's also the conversation happening elsewhere. So I think we've got that support role, and I think the key is working with government on this.
It is, because there's separate pieces of legislation. There's something about coherence on the legislative level.
And I'm sure Sport Wales colleagues will be really glad to hear that we're offering some support around this, because and this is something actually that directly impacts the work in Sport Wales, isn't it? So, are there any more questions on this for Tracy? No. Lovely. Well, I'm going to say I know Sport Wales colleagues have to get on with the rest of their day, so I want to say a particular thank you very much for coming today. We've had some fantastic conversation, and we look forward to attending your board in the future and working together moving forward. So it's very nice to see you, and we'll let you go now. Thanks. Thanks very much. And we'll make sure that the copies get distributed as well of your thoughts on manifesto. I noticed. And just I know. Thanks, great. It's very. Where's your black and famous? They're all in black and famous. Right, thanks everybody, and thanks very much for all the discussion around Sport Wales. I thought it was really exciting times moving forward with that. Right, so we're now going to move on to the next item on the agenda, which is going to Meng and Ian with the latest public health overview. So I'm not certain which of you is going to lead this. Ian?
I'm happy to lead off on it and I'll try to be quite brief with it, because I think at the last board meeting, Tamsin asked the killer question around, actually, is everything being broadly flat, good, bad, or indifferent? And I could go through a lot of the detail of the data, but actually broadly, everything is remaining broadly flat across all the indicators. And so what we're seeing is we're going into the winter with the waiting times not having improved. And also the healthy behaviours are broadly flat. The trends in mental and social well-being broadly flat. And the latest wider determinants data are also broadly flat. And so while I would love to come and give Tamsin a complete rundown answer about actually what does this mean, I think we've still got a further bit of work to do here around looking at the healthy life expectancy data and unpicking exactly what's caused the latest deteriorations and also the widening gap in inequality. And then looking at which of our interventions are going to have most impact, and therefore which indicators will it matter will it matter if they're not moving down or up, and which indicators are less important, because not everything is going to be equal. So we've kicked off a bit of work in order to really understand that driver of healthy life expectancy, which then feeds into the work on the performance report around the measurement framework, particularly around actually the outcome indicators, the policy modelling, so what of the policies will have the biggest impact, and then the evaluation parts, which will answer the part about actually it might not be moving in the right direction, but if we weren't doing what we were doing, it would be worse. Or actually, this thing isn't just having the size and scale of impact. So I'm not going to go through huge amounts of detail in it, partly aware of time and partly because I don't think there's that much new news. And I'm happy to hand to Mang for anything he wants to bring forward on the communicable disease area.
Thank you, Ian. And are there any questions for Ian at all on what he's just said? No, and I think Ian, we'll just look forward to the kind of further analysis when we get it, and recognise that at the moment you're just doing some further delving, as it were, into this, and we'll look forward to the next report from you. Thank you. Ben.
Yeah, thank you. So it was good to see the downward trends for C. diff infections across all health boards. And that's partly because of the increase in vigilance and also the support that Public Health Wales provides at the grassroots level as well, working directly with infection prevention and control teams. What's not heading in the right direction is the vaccination rates. And for many of the childhood vaccination rates, there are small decreases, but drifting away from the 95% WHO targets for herd immunity for most vaccination programs, which is of concern. Now, our vaccine preventable disease program continues to advise Welsh Government on interventions and provide surveillance data so that we can work with our health boards, who are the primary implementers of vaccination programs, to target the activity so that we can reduce inequalities, but also ultimately to improve uptake of vaccination. We're trying to work out ways of actually improving our data sharing for action, and that happens on an ongoing basis. where we're able to evaluate, such as the RSV vaccination program, we're providing that detail to our partners to help understand the impact, which has been very positive around the evaluation of the first year of the delivery of the RSV vaccination program. So it's ongoing work to mitigate some of the threats that our communicable diseases continue to have. And take this opportunity just to reference a couple of health protection incidents that have occurred. One in relation to the flooding in Monmouthshire, affecting many communities in Monmouth particularly. To say that Public Health Wales played an active role in responding to the major incident by providing a strategic and operational public health advice. The recovery coordination group continues to meet, and there is local health board public health representation there, and as such Public Health Wales has withdrawn from the recovery working group but continues to offer advice and support where required. The second is in relation to the exceedance and rise in the number of flu cases reported to our team, and we have provided expert advice to our system partners, including to the CMO, about what further interventions we can take to improve flu vaccination and also mitigate the impact of cases, particularly in high-risk settings such as hospitals.
Sure. Thanks, Ming. And just to comment on the general picture of decreasing C. diff infections, decreasing gram-negative bacteremias, and also lower and the microbial antibiotic usage. It's all part of the same picture, I'm presuming, which is actually a successful communication exercise and one that needs to be underlined and continually underlined, particularly as we go in the flu system. You know, don't take antibiotics, but it all looks as if that whole picture is coming together in a better way. Am I right?
You're right. I think this is an association rather than causation.
Yeah.
Because the data presented on the antimicrobial usage is actually lagging very much behind the reported cases of C. diff from health boards. But there will be a direct link to reduce C. diff rates through the reduction in antimicrobial usage.
And just again to underline immunisation risks. I know everyone's doing a lot on this, but it seems to be a continuing issue.
Sorry, and apologies if this is later and not in this one. I'm having an IT papers meltdown. But the HPV particularly, I thought was interesting, the dip in that. And I don't know if we've got any reasons behind that. You think of all of the ones, you know, grabbing people in the same year as school would be a fail-safe way of it not dropping.
Yeah, HPV vaccination goes hand in hand with cervical cancer screening as part of the WHO elimination target for cervical cancer, because HPV attribution accounts for over 90% of cases of cervical cancer. So it's really important that we combine that efforts. And we actually sent in a summary briefing to Welsh Government to consider how we can address both. I think for cervical cancer screening, we're very close to the 70% recommendation from WHO in terms of uptake. And with the introduction of the 5-year screening interval, that is now in excess of 70%. However, we're not close at all to the 90% recommendation for HPV vaccination. And that's now moved to a single dose rather than 2 doses. And I think our rates will improve as a result of that. But there's still more to do. And I know the team is looking at ways of improving the uptake rates.
Any more questions on this report? I think there is, you know, for me, there's just something about us understanding that if a line is flat and is not changing very much, is that because our interventions are stopping it from getting worse, as opposed to actually having an impact on driving profits down. So so I think that's one of those things that it would be interesting if we could understand that, because if things don't change, then there's always a feeling of, well, maybe it's because we're just not doing enough, we're not doing the right things, but maybe what we're doing are the right things, and we're stuck with stemming the tide, as it were. So that was just my question then.
And maybe one way of following that is to have trajectories of what's expected if we did nothing, and then monitor against those trajectories.
Yeah. I think that personally, I would find that really helpful.
I see that too. Yeah, I've obviously the majority of these, not all, we're quite far removed in making action, in taking action, because it's not our boots on the ground. Other than screening, obviously, we look at the IPR to talk about screening and the support we provide, and advice to the public around infections within the public. But as far as the NHS is concerned, particularly infections that are required for a patient whilst in an NHS premises. So we're limited as to what we can do, which is why it's so much about guidance and influence. But I do, Ian, you and I haven't had this conversation, but I wonder whether or not we should be sharing the public health overview with all health boards and local authorities.
Yeah.
DPH every 2 months is just a part of a normal. So it goes to chief executives, to us, public health board secretaries, local authorities, DPPs, because they are actually, that's actually where the magic happens. So maybe maybe we take it offline and just talk through the practicalities of that, because otherwise we're holding knowledge that not everybody's.
Yeah, I think that would be really helpful. Then.
And that work is in tow. So we've had the initial discussion with directors of public health in the first instance about how we share data that is essentially information for action. We've started that journey with our screening uptake data. So we'll be presenting our proposal to the directors of public health in the December meeting as to how we share it and what would be meaningful. So it's iterative. And as part of that, we will also share metrics across the performance of the screening pathway, not just uptake.
Yeah, and I think to Tracy's point, I think it would be really helpful to share that more widely as well. The chief executive, etc. Ian, did you want to come in?
Yes, please. Just the dashboard is actually available live publicly. So I think the thing here, Tracy, is how we draw attention to it.
Yes.
By no means comparing chief executives to horses, but it's how do we take the horse to the water?
Yeah. Most of them won't even know that it's available. That's the reality. Yeah, and that's the same, isn't it, with a lot of things that are available on websites, is you have to be proactive and go out and try and find it, you know. So if we can help by actually supplying this information, I think that would be really good. It's a great point. So thank you very much. Any more questions on this? Okay. So I think we can take assurance from the discussion that we've just had and from the actions that are going to be taken forward on this, and note the update. So thank you very much, Meg, Ian. And we'll move on to the next item on the agenda, which I'm just going to pass over straight to Angela. And Angela, if you could take us through.
Yes,
that would be helpful.
Thank you, Chair. So what we've got in the pack today is 3 reports, just for the benefit of people who are new to this. So we've got the cover paper, we have our insights report, and we have the finance report. So I'd focus my narrative on the insights report, which is the 58 pages, the second document. It's split into 4 sections. We'll go through each section and pause for questions at each section as well. So the first section on governance and accountability, we'll move through that section, and the first item on there is the people governance. And Neil's not with us today, but he did mention to me that, you know, if there was anything that anybody wanted to pick up, we could pick that up outside the meeting with Neil. There's nothing significant to report. We have built in the in focus section on sickness absence and appraisal reviews. You'll see them on pages 7 of 58 through to 9 to 58. These are the 2 areas that remain a challenge, and we're not achieving the required levels. So that's why the in focus section is there, as you know, highlighted there for more information on what action we're taking. So I know Neil's not here, so if there are any questions, then we'll take them outside the meeting today, if that's okay. So, moving on to the financial governance section, that's just highlighted on one page in the pack, 10/58, but there is a detailed finance report in the pack there. 4 things just to highlight for myself. On the revenue position, we deliver a break-even year-to-date position as at the month 7 report, and we are working hard on delivering our year-end forecast. As you would imagine, cost pressures do pop up in year. They highlighted in the report, but we have that every year. It is what we do. We manage our risks and opportunities closely. Tracy and I have met with every single directorate at the mid-year point now to go through plans through to Q3, Q4. We will continue to monitor that closely as we work through the remaining months of this financial year. On capital, Table E and Appendix B will give you a lot of detail on our discretionary and strategic schemes, along with the spending profile. And again, the same level of rigour on that is going on behind the scenes with our capital monitoring group and our scheme leads as well. We have had a significant amount of strategic funding, and that's what the tail end now is where we need to manage our focus on. And then update on the balance sheet, which is our statement of financial position, which is there for information and detail in terms of how we're managing the balance sheet, which I know we get a couple of sessions, but that's there as it normally is for people to see that. I think the focus is on the cash balance, which is always where the key interest is. That's a healthy cash balance. And then just to highlight the last point around balancing the in-year work now with the management of our financial planning going forward for 26, 27 and beyond. We always do that at this time of year, so it's no different. It's just part of our work programme to deliver that. So those are the 4 key items in the finance. And pause in case anybody wants to raise any specific questions on the finance. So good. Moving on to the next section, which is the corporate and information governance, which is 11 of 58 and 11 to 14 of the 58. Nothing to highlight in terms of the in focus section there. So I'll move on to the clinical governance, quality, safety, improvement, which is 14 to 18 of 58. And our in focus section highlights on externally reportable incidents. So I was going to ask Claire if there was anything over and above what's been highlighted in the in focus section that you want to bring to attention.
So the BTW incident we've picked up already and done some remedial action that there's more to do. And I think we'll feed that into the more general review of BTW, but also the broader IMT that's going on around the infrastructure, around the bans, which is about health and safety, water safety and the impact of the dust, which is impacting, as well as some infrastructure issues. So nothing further to report on those 2. And just to note, really good to see the FOI still going in the right direction. We are holding a couple of tricky ones at the moment, which are complex, relating to the water park, so Cosmos Lakes. I've got that right, yes. So really complex ones that are coming through, which involve multiple parties. So we're just working on those at the moment. They will come back as overdue, but we understand the reasons when they're far more complex. Of note, our FOIs are becoming far more complex and involving multiple partners. Any questions for Claire?
No? Okay, we'll move on to section 2. Section 2 is our service delivery section, and that's 21 to 30 of 58. And what we are highlighting here is the in focus section on BTW, BSW and DES. So there's a lot of detail in there, but if there was anything else you wanted to add.
I think it's to reiterate some of the metrics that you're seeing, which is a significant difference in the 3-week assessment for West Test Wales. The reasons for this are the fragility of some of the clinical resilience capacity. So there was sickness absence in West Wales, which is why we when you look into the division to the three regions, West Wales has dipped right down in the months that we were reporting. Now, the new PAC system allows us to carry out reading of the mammograms remotely. So West Wales has provided mutual aid support for North Wales, where the radiology capacity is very limited, a single-handed radiologist with 2 consultant radiographers. So I think specialist workforce continues to be an issue in terms of delivering an effective pathway for West Wales, and it's a major concern for me. And hopefully, and I'm confident that the Breast Test Wales review that's ongoing around quality and to identify areas for improvement is reaching its conclusion, and we will have an executive session to discuss how we mitigate and improve performance on an ongoing basis. But there has also been an escalation in North Wales to the chief exec, where there is a clinic that could be run by a radiology-led clinic, but isn't happening because the surgeons involved are not prepared to take any referrals from radiology-led clinics. It's an outlier, and it's certainly not consistent with our accepted standards. So I escalated it for urgent attention, because when you look at the graphs, North Wales has not achieved the 3B assessment.
Can I just clarify, it was escalated to the chief executive, but let's keep that well, is it? Yeah. Living it, breathing it all the time.
And it was Tracy, you're cited on
Yeah.
So that's where we are with Breast Test Wales. I'm happy to pause there and then move on to bowel cancer screening.
Has anybody got any questions? I've got Claire online who would like to come in. I'll go to you first, Claire.
Thank you, Chair. So my question really was around the differences in my contribution rates, and just to ask for what measures are in place to ensure that staff in areas with the lower appraisal completion rates, to make sure they're not disadvantaged in terms of career progression, training opportunities, or pay increments and things.
Yes. So Neil, unfortunately, is not able to attend the meeting today, and he'd be the best person to answer that. So if I could ask you to pick that up with him outside of the meeting, but then if it's something that we need to bring into the performance reporting or to PodCom, then Neil can speak to Tamsin, and we can make sure we put something on the agenda for the committee to have a discussion about it. But unfortunately, we can't answer that. I can't answer that one here in the room right now because Neil's not here. So,
okay.
But yeah, if you can get in touch with Neil, and he'll liaise with Tamsin, and we'll see where we can pick that up and make sure it's covered, because it's really important. Thank you.
Thank you.
Are there any questions around breast tests?
I was just wondering, so each health board decides on its own kind of standards. So you're saying that in Betsy Cadwell, they have their own.
No, so the Breast Test Wales programme defines the standards and expects health boards to align with those. But for this one particular unit, 3 units in Betsy, the surgeons have taken a different view. So what we're trying to do is restate the policy and ensure that we have the support.
So they're countering our policy.
Essentially, yes. They're breaching the conditions of the commissioned service.
And that's why you've kind of gone.
That's why I've escalated into
Okay.
of Betsy Cadwell.
And a public health way.
But it'd be really helpful, someone like me, to when you're doing the breast test Wales review, for me to understand the process, if you like, and if that's laid out in terms of who does what, which staff do what. So I can see that there's radiology, there's a surgical radiology, and then there's radiologists, and they do separate things.
Yeah, so if I might take the opportunity just to talk through the pathway. So women get invited at intervals at 3-year intervals to attend for screening. When they attend, a mammogram is taken, and it's usually done by a radiographer. And then the images are collected digitally, and then they're read by a combination of radiologists and well-trained radiographers. And there's usually 2 readings compared, and if there's a need for arbitration, there's a separate process to ensure that there is a process to determine whether a mammogram is normal or abnormal. Now, when it's abnormal, that's where the assessment then kicks in. So we've got a 2-week standard for the reading of the image, and then a 3-week from screen for the assessment connectivity. It is that bit that is currently an issue, and whereby in England and many other areas within Wales, there's an acceptance that these assessment clinics can be radiology led. So it could be a radiologist or a consultant radiographer. And these then allow biopsies to be taken and then referrals to be made to the multidisciplinary team that will have the consultant surgeons, the radiologists, and all the allied health professionals working together to come up with a care and treatment package for that individual. And our policy says that where a surgeon isn't able to attend assessment clinic, it is possible for that clinic to be radiology led, and therefore referrals be made to the surgeon from the outputs of that assessment clinic. In Llandudno, what the surgeons are saying is that we're not happy to take referrals from clinics that we're not part of. So that has meant throughout the whole of one of the months in the year, I can't remember whether it was August, we couldn't hold any assessment clinics because there was no resilience in the surgical input.
Which is totally unacceptable for women. Seriously.
Thank you, Meg, that's really clarifying, because I picked up bits of it and then I wasn't quite clear how it's lived. Thank you.
Could we ask the chief exec to feed back to us about something with the surgeons? And I presume there's an evidence base that this is all based on, because the pathway won't be, ad hoc, and the recommendation that radiology reading is adequate will be absolutely there in the evidence. So we've had this before, and I just wonder if we could ask for feedback.
Yeah. So the evidence is good practice guidance, and this is practice that is adopted throughout England.
I know, and further afield.
And for us in Wales, I think we wanted to go a step further and involve the surgeons. In fact, we're paying for the sessions to be involved in the assessment clinic. But for this one unit, we're not able to apply our, continuity arrangements where the surgeons aren't available.
And yet we're commissioning surgeons. I just think it's just a matter of principle. We need to know how it's going to move forward. Because women are suffering and the population is suffering. So I think professional pride could be discussed.
So my question was about, I think I know the answer, but can we commission service from another local provider? Because clearly if it's unacceptable, it's unacceptable. And I don't know, we escalate that further, but we are the commissioner of the service and we should consider alternative ways of delivering that service if the health board is unable to deliver the service that we are commissioning.
So the options are limited. If we want to offer treatment for women in their locality, we would then need to look to other health boards. Then there will be logistics about the surgeons actually travelling up to North Wales to provide that service. So I don't think, in a practical sense, it's possible to commission from another provider. I think the solution is to improve resilience and to widen the pool of breast surgeons who will contribute to the service. And that is the matter for the health board to discuss. I had previously escalated it to the then interim medical director and then the new medical director. But the management structures are such that they only have a professional oversight, but not direct line management. So having hit that barrier, I decided the best action was to escalate it. That was done a couple of weeks ago.
We have done exactly that before, screening services, where a part of the country, and it wasn't North Wales, was so underperforming that we went out for an expression of interest. We just withdrew payment from them, and we didn't give them the whole lot at the beginning of the year then, and we've talked about changing the whole payment profile for health boards going forward. And so we went to act for an expression of interest with health boards to say he was able to pick up capacity. And I think it was a combination of screening participants travelling a bit further, but also the particular health board that stepped in and did a really good job. Also just looking at where they could be closer to the border of the health board that was in trouble. So we transferred the money. So we commissioned them on short term for picking up. The challenge with Breast Test Wales, as Menga said, is radiologists are as rare as hen's teeth. And whilst we've got amazing consultant radiographers, you still need to have that clinically governed oversight there. AI is a really important thing to think about for the future, not to replace all the humans, but certainly parts of the steps. So if we did it for Breast Test Wales, we probably wouldn't get anyone who has got sufficient capacity to do the additional full screening participants in North Wales. That's the challenge. Doesn't mean that we can't look over the border though, to see whether or not we can get Chester involved, because at this point in time, I really don't care as long as people have the. So we have actually done that previously. We have threatened to do it as well in other parts, and they've responded. Similarly, we've got similar challenges around bowel screening, which we'll come on to, and that's because of capacity around colonoscopy. So there is not resilient workforce in the NHS around diagnostics, whether it's colonoscopies or whether it's radiology, quite specifically. So we will look at all options, including in North Wales, going over into England. But there's a challenge everywhere around some of these specialist roles where there's just not enough coming out of training. So we will look at everything we can here. I think that some of them, we just know that the rest of the country can't step up because they're struggling with capacity themselves. It's a broader conversation about how do we run health services and where does diagnostics sit and everything else, to be honest.
Just to add that this specific issue isn't about the lack of capacity, it's just about the two individuals.
About power bases amongst the different between medical professional groups, which is just not acceptable.
Well, it's not acceptable, and I think we should withhold payment if they're not delivering on the commission service that we expect from the commission. Then I don't think we should. I think we should withhold payment, and I think we should start seeking that expression of interest from an organisation that is capable of delivering for us. We might not get an expression of interest, but I would certainly support that at this stage because I don't think it.
And I think let's give the chief exec an opportunity to come back. Yeah, they're probably not slighted on any of it.
Yeah.
And if it was me who saw it, I'd be saying, what on earth's going on in the organisation? So I would suggest, if I may, that let's see what they come back, because if they sort it out, it's it unlocks this. But we have to be on the escalator of intervention if we don't get a positive response back.
Yeah, I agree with all the points we made, and it is really disappointing, isn't it, that behaviour is driving this and it's impacted on women. This is all the right thing to do in terms of the negotiation and the conversations we're having with the chief exec, but another useful tool is the Cancer Network. So they do peer review and they've got a cancer site group specifically around breast. So if they were to come and look at a bit of a mirror in terms of peer review, it'd be quite powerful. I'd go through got the name of the board now that sits in NHSP&I, the clinical framework board, which is chaired by the CMO thing at the moment. So that would be, I think, a really helpful route as well. I'm sure Tom would be keen to support that.
Yeah, I mean, I support absolutely the process and think, we need to give them a chance. Just if we go beyond that into escalation, do we have a mechanism for making sure the wider system, Welsh Government, etc., are cited.
Yeah,
Obviously, they have a performance management role, and it's another way to come at the same.
Yeah,
Making sure it's coordinated and we're not always trying to do something against the system.
Yeah, that's one word that I had written down was escalation. I think it's the first thing I would say, Meng, is that I think it's important for the board that you have identified this, you immediately escalated it, chief executives involved, moving it to the right level, and that it is in that process of escalation. And so I think from our perspective as a board, then we quite assured that, you know, we're taking the right actions because this is such an important thing. And so I really wanted to just highlight that, say thank you for raising it and making sure that something happens quickly.
Yeah, and I would say we have got other challenges in BTW, not just in North Wales, hence why the review is going to be so important. Yes. And obviously, once the review is concluded, we'll be briefing the board on the outcome of that thing. Yeah.
There's nothing else on breast test, and I think we'll probably move on to bowel.
Yes. Oh, that's all good news.
The board will be aware of the escalation process that we undertook through the summer, where Tracy and the counterpart to each of the health boards met with the programme teams to look at screening colonoscopies where there was an unacceptably long waiting time that was deteriorating. And you will notice with interest that in the month of August, the wait times actually reduced, and that was the month that we went out to have those discussions. So it is possible for health boards to, you know, improve in the short term the position around the wait times, but the month after that you will see that it's kind of gone down again. So what we have done is pull together a report with all the learning from across the health boards. We will take it to the leadership board in partnership with NHS Performance and Improvement to carry out a diagnostic piece of work to look at what the long-term solutions would be. And the themes that are emerging around lead-in times for JAG accreditation, which is training that colonoscopies need to have before they become a screening service. Encourage people to take on board clinical endoscopists who are not necessarily doctors, but can be trained up to 5 years. Currently, I think there are only 2 in all of Wales. And also to have the parity of esteem between referrals from the screening programme and the symptomatic referrals from primary care. So all those interventions gives us a way forward in terms of improving this. But I think on average over time, the average delay is shorter than before the escalation process we had taken, but it's still nowhere near where it is. And I guess the real concern is that treatment can't be offered to people who have the disease in a timely manner. And as the clock ticks, there will be a disease progression that we will need to be minded of. In terms of bowel cancer, the disease progression is probably within tolerable range, but with the delays in breast test Wales, it might not be. There is evidence of a natural history and progression, and we can, you know, estimate what the clinical impact is, what the level of tolerance is. But I think we're not quite there yet for bowel, but we might already be prepared for that.
Yeah, thank you, Meg, and also thank you for the way in which the data and information is presented here, because when I read this, I was immediately struck by you know, that I could actually see what was happening across Wales, that I could see what the trend was. So for me, I found it really helpful. So I just wanted to thank you for that. Has anybody got any questions, Claire?
It's just, I suppose, it's this behaviour as well. So for me, obviously, the performance increased in August, and I imagine that's because they did what they always do when there's the pressure on waiting times and pay as much money that people over some hours. And then we've got running parallel to that, what I would imagine is a pretty well established answer to the issue, which is around, using more of a multidisciplinary team. It's about people working to the top of their license. And I imagine, and I know this isn't an us thing, but it's a system thing, I imagine that we've known that again for quite a while. And I'm just wondering, I mean, obviously the pressure that finance on everybody is going to be a great big playing into this, but is it that, and or is it the same again? Have we got teams of people, let's just call them doctors, because that's what they're called. Like, we need to do this. Is it a trust thing? Is it a culture thing? Or is it purely a finance thing? And have we got a timeline for when we might go from the plan that probably everybody knows what it is to actually being able to get with? And I know this is on us.
Yeah, so we have contract management meetings every month with each health board. Finance is clearly a driver, and next year we're going to put in arrangements where we actively withdraw funding for underactivity. We've not got that mechanism built in clearly into our current long-term agreements with health boards.
That would be for BTW as well as house.
It will be, of course. But I think coming back to Val, there are also logistics about the availability of endoscopy suite space and the balance between that and the symptomatic service. And then there's also the logistics about the lead-in time for JAG accreditation, which currently is 2 years. There are people who are keen to become it, but this process is good. So what we're doing is internally reviewing whether we've set the bar too high. But, we set the bar too very high because the pass rates for people having undertaken the 2 years is very high compared to people who, say, in England, undertaken a similar training for a year where the pass rate isn't as high. So I think we're looking at exploring the interventions we put in place, but we know we've got some tangible actions we can put in place for the JAG accreditation.
Okay. Yeah, and so we're sending a letter to them to just kind of close off the process we've gone through and asking them for their detailed plan to regularise, to sustain to performance. I can't remember what timeline we said that we were going to give them to do that. It was very different, very variable in many respects across different health boards. One health board saying that their consultants prefer to do screening colonoscopies than they do symptomatic colonoscopies, and others saying, well, we just don't have the staff. I frankly think people haven't given it the importance that's needed, and the reason why it's a higher level of training is because these are people mainly who are just a normal population who don't have symptoms or signs. So the nuance changes. You've got to be really looking actively for it. Whereas if you tragically appear with symptoms and signs, you're going to find something, probably highly likely. So that's why it's a bit more. It's a bit more in depth to train. But it's the most traditional, old-fashioned model. I mean, involved in setting up the bowel screening system in the Republic of Ireland, it was from the outset, it was clinical endoscopist in a clinically governed service. We've got 2. And HIW put money in to train a good number, and then that's just petered out because people aren't getting jobs. So there's an almighty, no health boards railed against that. It's just, we have to help them to do it. So there's some system stuff that we need to help with as well, but I just don't think it's been important enough on people's radars. And yet, ironically, is if we can really get this right, it improves outcomes, it improves people's lives, and it reduces the avoidable burden on the NHS of someone who presents later on at an end stage, notwithstanding their quality of life. So
Yeah, I just think we need to be careful towards the end of the year because it is sometimes about prioritisation. House boards will have significant targets around delivering their routine endoscopy work. So we just need to keep an eye on that because we're one of many competing priorities that run through house board waiting times as well. So what you think on that.
We did send an SBAR into the Cabinet Secretary. We briefed him on bowel screening miles a couple of meetings ago, a number of months ago, and we sent quite a detailed SBAR in to him so that he was very clear on what the state of the nation was. And Welsh Government have been having their IQPD, I never know which word order, meetings with health boards, and they have talked about bowel screening, but it doesn't really go any further than that. So,
Sean, finally.
No, I was just going to say, I find quite good to see some data, like how many people are we talking about, and modelling around early intervention and later intervention, and then the costs associated as well as the mortality, because this is an avoidable mortality issue, and it's a burden of care issue. And I just wondered if you could find the data, May. Someone must have got it on the council. Yeah, just to have a look at, because it's such a common disease, and Wales cancer figures are not good. So it's an issue of something where you could make a difference. I'm sure. Same actually for breast cancer, saving lives by intervening early with screening. I mean, you can see why health boards won't see it as important as all the other pressures on them. But I suppose that's our system leadership role, which has a direct impact on the population. Be very interesting to.
So I know we're all interested in early presentation, early diagnosis of cancer, and Ian's team, and the screening team, is putting a program of work together to replicate some work undertaken in England with a route to diagnosis. So,
and outcome. Because
yeah. So one step at a time. So understanding the route to diagnosis will give us, I
haven't said it for months, have I?
Sorry. So understanding the route to diagnosis will give us the rationale for encouraging people to attend screening. And we know that inequalities.
I was actually talking about something different. I was talking about what does the total global population picture look like, not our screening data.
At least the total population. So if you present to screening, you're going to present with earlier disease. If you're presenting to A&E with symptoms, you're going to present with later disease. And then the mortality and morbidity arising from each of those presentations will be mapped through the data linkage to our cancer registry. So we will look at outcome data as well, but this gives us the ability to say, actually, these communities are not coming forward for screening, and there's a missed opportunity there which impacts them.
I think sure, that's one point of it, but I was talking about something slightly different.
I think
the overarching picture. That's all. Don't worry, I'll take it up.
Yeah, I was going to say, Sean, it'd be really interesting actually, because I know exactly what you mean in terms of how much money is this going to save, how many lives is this going to save, not for us, and some modelling. So perhaps what I suggested, Maine, is that you and Sean just connect outside of the meeting so that we can get an idea of what that looks like.
Yeah, and maybe just to help. So recently we had a meeting with Isabel, CMO, Sabina, myself, Ian was on leave, and Ian, she's asked us to look at the impact of waiting on outcomes. So Ian, it's worth this conversation adding screening into that. So across a number of conditions, because everyone's talking about time, but actually people who are waiting across a number of clinical pathways, how is that impacting on their outcomes? So we're going to be doing that as well. So I think looking at the combination of both what we're talking about will be quite helpful. Yes, I think that would be very helpful. And perhaps linking it with Ian, maybe.
Yeah, with the screening programs, National Screening Committee will have published all the assumptions about lives saved, economics around it, so we can dig those out and share them with you.
It feels like a topic that could merit some really detailed discussion, perhaps at committee level, rather than coming to the board. And perhaps we could think about putting it onto a committee agenda, and then or possibly more development. But just thinking about having the opportunity to have a bit of a wider discussion about that sort of whole pathway and the impact it will have on society, people, and also health boards as well.
Yes, and we've got a session with Sharon, haven't we, later?
Yes, yes. So might be able to as well.
articulate some of that then. Claire, you're
Yeah, sorry.
going to get the last word.
I should have mentioned it again. I just wonder, in light of this being a tricky wicked issue, you may have had this conversation when you met with chiefs and the health boards. But do we need to think about a trajectory for improvement that we hold them to account to? Because we know where the target is, we know where we are, but we're here, we're doing all the work.
We're asking them to come back to us with a plan, a recovery plan. So yeah, because we, you know, it's performance managing them for the service that we're commissioning.
Improvement.
But I don't think we've ever asked about that before. So yeah, that's part of the letter we go to.
Lots of interest and discussion. Angela?
Desu.
So, I mean, DESU has a transformation program that's looking at interventions to improve our position on wait times, which is stabilizing, having had a bit of improvement earlier in the year. The challenge here is the increasing eligible population with a number of with diabetes who will be screened lifelong. So we're looking at ways of how we're going to improve efficiency, effectiveness of the pathway. One of the things that we will be considering is not using eye drops, because the latest technology, the cameras that we put in place last year, are producing such high quality images that we may not need to dilate pupils. And that will have a huge benefit for patients and participants, but also for the service where the throughput will be much greater. So hopefully that will lead to a better timeliness of screening. And then other bits of the business, which is infection division and health protection, you will notice health protection it usually exceeds the standards that are set. So I have gone back to the team. Well, I had gone back to the team to ask, are there other metrics that we might want to share forward? And they have come up with one which is really important, which is the production of outbreak reports following the closure of incidents and outbreaks, which is in our clinical disease plan for Wales as a standard. So I thought it would be a role modelling for us to actually adopt that standard and report it. You don't see it here, but it will be in future reports, and Angela's team have taken that into account. And then infection services, again, these are unchanged, but when we have the next iteration, the metrics will change to around times for some of the services that we offer.
So, thank you.
Thank you. So the rest of the section, there's highlights in here on RD&D, which is Ian's Directorate, and Samina's Directorate of Policy International Health is included in this section too, along with Jim's Health and Wellbeing key programmes, and that takes us all the way up to page 37 of this report. So in the interest of time, should we just ask if anybody wants to raise anything else? Yes. To move on to the next section.
Unless there's anything. No? Okay, that's great. Thank you, Angela.
So section 3.
I was just curious, Samina, it says that the targets are being developed around policy and international health. Just to have a flavour of what they might look like.
Really difficult. Happy to chat outside, because a lot of our work is our work is very varied, and it's not service delivery. So it's an ongoing conversation we've got with Angela, your team. But we're developing outcome indicators as a director if they're in point. So I'm happy to link in on those. But they're not easy, that's all I can say.
Sounds like a good conversation to be had outside of the meeting. Thank you.
So section 3. Section 3 is our update on strategy delivery. And I'll draw your attention to a new slide that we've put in, which hopefully helps address the action from the last board meeting, and that is on page 48. So what we've included in this section, over and above the usual update on our milestone delivery and delivery by milestones, each of the strategic priorities, is on page 48 of the pack, is an overview, and I've just spotted an error in the title. It should be ITP 25-26. Changes to the baseline. This was around some analysis that we've done to show the reasons for our request for change. And this was highlighted last time in terms of the resource and the availability of our resources to try and give some more context into why those requests for change were coming in. So hopefully that provides the board with some more assurance around how the plan is progressing.
It's really helpful.
Can
I, sorry,
yeah.
Angela, if I can just add, just so non-exec colleagues are aware, so we've just about to finish our mid-year directorate reviews, which is obviously we have kind of tailored version of this for each directorate. And there's a lot going on in the organisation. There's a huge amount of change going on. There's a huge amount of preparation for change. And given the financial challenges that we're going to have to manage between now and next year, going into next year, we need a bit of wriggle room. So I have said to everybody, I want them just to revisit the key actions that we've got between now and the end of the year. So if there are milestones that really, quite frankly, were kind of nice to have that can move in justifiably to the following year to create a bit of space to work this through, then I have no problems with that. So I say it every year. I've said it every half year for the last 2 or 3 years, and hardly anyone ever does it. But just to let you know that if that does happen, some of that is because I've asked people to do that. That's really helpful. But it's got to be the right ones, not the wrong ones. Nick?
I mean, just thanks. I mean, it kind of reinforces my point was last time, and I'm pleased to hear what you said, because it does give us a flavour. Was we started the year with a plan, we asked the question, do you have the resources planned? The answer was yes, and then the most popular reason for moving it was a lack of resources. And it was just how there was a point about having had the reflection about, is it exactly what you've just described, which I recognise, or was it the planning wasn't quite up to it? Can we learn something for the future year? We didn't really get an answer to it. So it's helpful to keep giving us that flavour of it, but it's about that. Do we need to learn so that next year we either give ourselves the wriggle room or not? But I think doing that this part of the year when we see that on the page, I think it's a very sensible approach. Fully support it.
Yeah, I think it's really helpful too. Colleagues who've been involved in PodCom meetings with me will not be surprised though that I always switch when I see something that says other. A vague answer. Yeah. And we've been unpicking other, for example, in the PodCom area, haven't we, in terms of reason for absences and leaving and things. Just it's the second highest reason in this list. Yeah. And I'm looking at all the others and I can see the logic of all the others, but then I'm thinking what's in other. So as long as someone's unpicking what other is somewhere and we can get some sense of, because I just sometimes feel it's a space potentially where if people aren't certain what's going on in their area, they go, I don't really want to commit to one thing, so I'll say other. But that doesn't necessarily help us, does it, to help them to unpick whatever that challenge was? So I recognise it's there, but it won't surprise me that I picked up on it.
Yeah, so it's something that we have picked that up when I saw this. So what we've said we'll do is we're not going to give other as a drop down going forward. But what we did do is unpick that other category, and 4 of them were just amendments because there was some duplication. So half of that 8 drops down to 4, and then we need to unpick the reasons for the other 4. So
but that's really important for us to know that, because that's, as you say, in terms of reassurance, that's just people going, I didn't quite know what to put, so I put that. So yeah, I'm just not a fan of other. It's the melting pot for who knows.
Yeah, that's really helpful. Just on the resource issue, I guess just to kind of put in perspective, that's 8 of everything in the last 8 months.
Yeah.
So I mean, and amongst that, there'll be small milestones and there'll be some of the bigger milestones. So, but quite a lot of the resource is because 1 or 2 people have been off sick, and so it slowed things down. But we spent more time doing the resource assessment going into this plan. I mean, Ian and the team particularly really detailed, and we went around the table so many times saying, "Is this deliverable? Yes, 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 yes." But our challenge, and Jim, we went into detail with health and wellbeing yesterday, was no more new stuff. Stop being so helpful. Nothing new shiny bits, because we work so closely with government. I'm not criticising government. Often we're asked to do stuff, and yet resources don't come. And we're going to be going into a year next year where we absolutely can't do that. And every year we have scope creep because something will happen. The minister will have which is which was ever this. an interest and asked us to do things, and we have to reprioritise. But I think we have to be really strict going into next year, because we're going to be potentially 3%, 5% savings, and we will not have the wiggle room. Hence why we're kind of trying to do that. Yeah.
Yes, very helpful to receive it. I like it.
Thank you. And then just section 4 to go. So this was the outcomes measurement, and I know Ian wrapped some of this up in his earlier conversation that we had. So I don't know if Ian wants to bring to the attention anything on the outcomes measurement slide, or did you cover everything, Ian, that you wanted to earlier?
I covered everything. I think we need to earlier, Ange. Thanks.
That includes the update on the integrated performance report.
Thank you very much, Sean.
Just to say, the heat related mortality data was interesting. That's page 56, 58. And that's again a preventable issue and ties into Samina's climate change work.
If there aren't any other questions on this, Angela, did you want to say anything about the financial position? And then
covered that off earlier.
Right. Okay. So if you didn't want to add anything further to that, then what I will say is I know we're running behind, very much behind. Very sorry, bad sharing. But very detailed discussions, I think, which is the most important thing. So what I suggest we do is take a very short lunch break and have everybody back here at 10 to, so that's 20 minutes. That should give you enough time to grab yourself a cuppa and to eat quickly, if that's okay with everybody. We will, I'll Everybody, and we'll go straight on to the next item on the agenda, which is screening services. So I'd like to Meg, you could introduce your team, please, and then we'll take this presentation.
Brilliant. Thank you so much for this opportunity to spend some time to familiarise the board with some of the opportunities and challenges that our screening programmes face. And we talked earlier today about some of the performance metrics, so people are familiar with the mitigations that have been put in place. But this is about how we oversee those programmes, how we consider on an ongoing basis the performance of the pathway, and address some of these issues both in the short and long term. So Sharon, the Director of Screening Services, has put together a presentation and a paper outlining our current position, but also our future actions. And with Sharon, we've got Bethan Bowden and also Graham Brown, who's dialed in online. And together, they're going to present the session. So over to you, Sharon.
Thank you very, very much, and thank you for the opportunity. Really great to be here. So the purpose of the session is just to outline across the screening programmes where our services are, challenges in the system, and actions and opportunities. And I understand from Anne, you've had a bit of a detailed discussion today, so please, you know, I don't need to go into a lot of detail on that. I'll manage that. So starting at the start then, population-based NHS screening programmes, what are they? Well, they're established programmes that we're looking for early signs of disease or condition in people who do not have symptoms. So it's all about prevention. It's getting there early. It's finding things at an early stage or preventing them occurring. And we know that the screening programmes that we deliver can save lives and improve quality of life. And those are evidence-based in line with the UK NSC National Screening Committee recommendations. Screening that we implement has more benefit than harm at a population level, and it's really important that people make that informed choice to take part in screening, as no screening test is 100% accurate. So what do we deliver across Wales? So Public Health Wales delivers across the whole of the Wales the 8 screening programmes across the 9 course. So in a little bit more detail, we have breast screening. That aims to detect breast cancer early to reduce mortality and morbidity. Cervical screening increases the incidence of cervical cancer. Bowel screening detects bowel cancer early and also removes polyps from those who have polyps, and that reduces the chance of bowel cancer developing. Abdominal aortic aneurysm screening is to identify aneurysms to prevent them rupturing. It has a high level of mortality if they rupture. Diabetic eye screening to prevent sight loss, and 2 newborn screening programmes. One, blood spot screening that identifies 9 conditions in newborn to make a real difference in terms of the baby's outcomes, and newborn hearing screening detects hearing at a very early age so you can do something about it to reduce that impact. And then antenatal screening has a range of screening tests offered that reduces mortality and morbidity for the pregnant woman and their babies. So we offer screening across the whole population of Wales, so we're impacted by changes in the population. And this board will know very well that we've got an increasing ageing population in Wales, and we also have an increasing population of people living with diabetes, and that's projected to increase. Also from work that Public Health Wales has undertaken and published is that we know that we've got an increasing cancer diagnosis due to that ageing population, and we've made some projections on that, and that's because of the population getting older. So what can screening do? Well, screening can make a difference in improving those outcomes because of that purpose in terms of primary and secondary prevention. So just a few slides in terms of that. So on the left-hand side is the cervical screening incidence, and that's going back to 1970s. So cervical cancer was about 25 per 100,000 in the 1970s. And when a systematic screening programme was implemented across the UK, you can see that reduction in terms of cancer incidence. We're now about on the 10 per 100,000. And actually, when you look globally, So cervical cancer is the fourth most common cancer amongst women globally. In Wales and the UK, it's the 14th most common. It makes a real difference. So we know regular screening makes that difference. We then looking at breast cancer, we know by introducing breast cancer, reducing deaths from breast cancer by 20%. So quantifying that, 180 women attended the screening and prevents that one breast cancer death. And looking at our aneurysm screening, when we introduced the screening program in 2013, we were on about 138 admissions with rupture of triple of aneurysm, and that's reduced after 10 years to 44, and that percentage of death is actually halved more or less as well. So it's all about doing things and finding things early. So this organisation delivers the screening programmes across Wales, and we align very much with the duty of quality. We've talked previously around aligning our programmes in this way, and we've outlined the STEEP principle, really focused on screening. It's a really helpful focus for us. So how do we manage the performance? So when we talk about screening, it is a test, but it's not just the test that would make a difference. Going back to cervical, the cervical screening was around before the real implementation of the programme, but it wasn't making that difference. It's a whole end-to-end pathway that makes the difference in outcomes. And these pathways are complex, so we work within the system, across Wales, within our health system. Some of them are repeat invitations, some are one-off invitations. And it's moving that SID process, identifying that screen detected population with that need for the test and then moving the system and keeping that right. So how do we manage that? Well, you will see metrics come up to the board really, and they're very summary metrics. They're mostly focused on timeliness, but the programmes have the metrics for each path to that pathway along that pathway, and they're keeping monitoring these. And this goes through the programme structure and senior management team. Quite a bit of red on that, but actually some of those metrics we're putting in as indicators of the overall metrics, and some of them we've made advances such as the fit test and bowel screening. That's bowel for an example. But you'll see one real area of focus is colonoscopy rates. So if I pick up some of the things on the screening programme specifically, so bowel screening, and we've optimised the screening programme now in Wales, which puts us in a really strong position to be making this impact, which means that over 500,000 people we invite in screening. Screening has got vast numbers coming through. And from that, we know that about 2.5% of those that are screened have a fit positive, and then we move them through the colonoscopy pathway. And we get a good yield of cancer detection rate and a very good yield of pathology. And we can quantify the number of people that have been screened and bowel cancer detect through less than 60 now, which is kind of just over 300. But the issue in the bowel screening programmes that we're really focused on is our colonoscopy rates. So we know that there's two parts to that. There's the screening and practitioner assessment, which is within standard, but our offer by the health boards of our commissioning service and colonoscopy is not within standard. And that's a real focus of the programme, which you may well have received coming through and you may well have touched on this morning. The challenge is that health boards don't have enough core screening colonoscopy list planned and delivered, despite there being funding. And that's not because they don't want to, because it's really difficult for them to do that, because of the staffing availability of screening colonoscopists and that PPC demands and the accreditation programme taking place. So we've got some key actions that we're taking through with the health boards, and we're expanding that school of accredited colonoscopists and also working to streamline that process. We've got a really good tracker that's sharing the data across the system now, so everybody knows those waiting. And really helpfully over the summer, we've had some really constructive chief exec discussions with the health boards and our plan to send letters on next steps about that. So what do we need to resolve there? Well, it sounds simple in some ways. We just need the list that we're planning to do to be offered routinely. So if we look to see could we recover the list by the end of March 26, we really need to be across the health boards upping the core delivery of those lists consistently, and that would resolve it. But they are more than the list that we've got currently, and that's what we need to work with the health boards to get that core routine activity in place. So lots of opportunities in bowel screening. We're doing a really exciting piece of work with Cancer Research UK about moving through the colonoscopy pathway and making sure that people are supported through that and take up that offer. And then we also provide symptomatic fit service. So this is across the system for people coming through primary care who get symptoms, and then they get offered a screening fit test, lower threshold to really increase that yield and that appropriate pathway on colonoscopy. Moving on to the breast screening programme, it's a really large screening programme again, and it's just under the uptake rate. And we are identifying a considerable number of breast cancers early and at that stage where they're invasive, but they're too small to feel, and they come through the programme in Wales. The issues that we've got in breast screening are really good in the programme identifying the breast cancer in the population. The uptake is just below the standard. The focus that we've got is timeliness to the assessment weights. So we want to be offering women an assessment 3 weeks after they have their screening mammogram. It's really ambitious. We want 90% to be in that range. That means the person has to have the mammogram. It has to be double-blind read. It has to be arbitrated and invited to the assessment. And we're not there. We're not meeting that standard. It's different across the regions. So South is improving picture, but not within standard. West region is mostly within that standard, but not quite at that 90% rate. But North is really quite outside that standard, and it's a really uncomfortable weight that we've got to North. And that's mostly the focus that we've got there. So we know that we haven't got the right staffing up in North because we can't recruit. So we're training our staffing. We've got 2 clinical staffs, staffing and training, which will make a difference when they're working trained and fully independent, but that's not currently the case. And we're managing a backlog situation where there was surgical sickness and one of the clinics that up in North weren't able to run for 6 months. And we've got constraints in that pathway. Working really closely with the health boards about that and working to see if we can have a similar pathway in North that we have across the other regions, where if the surgeons are not available, we can run the radiologist-led clinics. So what do you need to get to timeless? Again, we're focusing on North. We have 40 slots availability in the North. We have about 25 slots coming through on a weekly demand. And again, if those 40 clinics went ahead, didn't get cancelled, we would be able to recover that position in 9 weeks. It's just the variation of that clinic. It's not, it's the fundamental here, it's just having resilience in that process to manage our capacity. So we are working with BCU, and we've raised the exec level. We really need that surgical model to have resilience because of small numbers of people staffing that we require on, and we need flexibility in that process and that pathway, which we have in the areas. Lots of opportunities in breast. We are implementing MRI provision for women at very high risk of developing breast cancer. That's in the South East and will roll out across to the end of this year. Really cross system working on that, and really key because these are women at very high risk that need an MRI. And we're obviously undertaking the breast screening review, which we're really grateful for and really excited about finding. The data's, they've shared lots of information with the review team, and we're now planning those one-to-one discussions with focus groups. So when that comes out, the recommendations, that'll be really fantastic. Cervical screening Wales runs really well. We've got some issues in terms of working on that coverage and that uptake. We've got a few projects in underway behavioural insight science. But the one key thing on opportunities in cervical, which we're really excited about, is we're taking forward a project of HPV self-sampling in underserved populations. We hope to take that forward next year. And these are the women who don't engage with the programme. They'll be offered that proportion will be offered self-sampling and see if we can engage in the programme that way. And that's based again on evidence-based in UKNSC to provide that permissive decision, which is really exciting for us because it's something specifically working with an underserved population on that. Moving on to diabetic eye screening. So diabetic eye screening is a really large programme. We've now reached a few 100,000 eligible participants, which is a very vast number, and a large proportion are participants invited every year. So we've got issues in terms of the timeliness here, in terms of the offer of screening. We know that people take up their offer, so the uptake is over 80%. And we're really good at offering newly diagnosed diabetes that first screen within 3 months. We consistently meet that target. But when you consider that Like, for example, in October this month, there were 1,600 participants came new into our population. That really offsets our ability. So challenges is the growth in our cohort. And as I said, we know that our population level. So what we're doing about that is looking what we can do within the clinic capacity of improvement projects. So we've got 3 projects underway because we know there's a shortfall of about 1,000 per month in terms of that capacity. We know the low risk recall pathway being implemented is working to manage some of that capacity, but actually there's still a shortfall. So we're looking at different clinic models, such as the 2 that are looking really positive are the low risk recall pathway clinic, where we have shorter time periods and bring in less complicated participants so we can increase throughput, and then dropping clinics where we're adding additional people within those appointments. But then we don't think that's going to get us to where we need innovation, and what we're taking forward on that is taking advantage of the new cameras we've got in place, where we can stage approach and review the images to see if we can take images without doing the eye drops, and we're doing an exploration of that and an evaluation project planned in February this year. And if we did that, that would make a step change in terms of the clinical capacity that we've got. It's taking the eye drops and then waiting for them to take full effect, and then taking the screens a really limited part of the process. So that's really our plan, is for evaluating that and then implementing that will very likely make that step change we need in terms of capacity. Other things that we're doing really around the equity is taking forward an intervention on non-responders. We've done this first with the aneurysm screening programme, where the health protection support team will be skilled to undertake interventions on contact non-responders to the first screening invitation. And that's just about 3 to 6 months. It's really exciting. It's increasing those that are accepting that screening invitation, but also it's increasing the yield of the aneurysms identified. So it's really targeted at those population that we need to do it. We're also doing this in diabetic eye screening for defined populations, and looking to roll that out in bowel and spinal for defined populations. Moving on to newborn blood spot screening, we are working to implement new recommendations by the UK NSC, and working really hard, really grateful to the digital team working with us to make the changes to the IT system. It's the IT system, the first phase is completed in the summer, and we're now starting the second phase, which will enable us to put new tests on. And also, we know, working with the newborn screening laboratory, we need to move to make that change happen. And within the programme, the focus of the programme is about avoidable repeat rates, and also the newborn blood spot fail-safe. Because timing this improved, we're able to move earlier to make those checks with the blood spot cards come in. Lots of opportunities in newborn blood spot screening, several conditions that are going through in-service evaluations. And once we're in a position where we've got our IT system and the lab is on the footing, we're really well placed in Wales to make those contributions to the evidence base. Newborn hearing screening again performs really well, and we're looking at improving that service model, where we move from a both ear clear to model, so that we're making sure that those babies who do not have both ear clears are referred into audiology. And it's really interesting what we're doing there is trying to improve the specificity of the screening test. So as we move into that different model, we're not overwhelming audiology. But then audiology really positive and working closely with them. You'll know about the lung cancer screening programme. I think this might be on your agenda today. So we're really excited. That's going to be a really significant programme for us. Lung cancer is the highest cause of mortality from cancer deaths in Wales. We've submitted now the business justification case, and the programme's got structure and governance and taken forward that work. And then there will be always future recommendations, always a moving piece in terms of what's been explored and what's been discussed. So we know we've got 2 recommendations we're working on, and there are other recommendations in the pipeline, and other changes to the screening programmes, which we're really well placed to know and take those forward really to make a difference to our population. Thank you. Sorry, I will.
Thank you so much, Sharon. You know, there's so much on the horizon, and you're very much engaged with the National Screening Committee. And of course, one of the rising areas of work is around prostate cancer screening. There's a lot of coverage in the media at the time about what is the best test and what is the likely impact, because we know that men die with prostate cancer than of prostate cancer in the majority of cases. So that's ongoing development, and I'm sure when the evidence is reviewed, we will be in a position to provide a little bit more information about that. So thank you.
Lots of information in that presentation. Yeah. Has anybody got any questions? Nick?
I mean, firstly, great amount of information. Fabulous. Thank you for that and sharing it with us. I know you were taking us through a pace on that. I suppose it's two things. One observation that somewhat surprised me and one question. The observation was I was amazed that in the child hearing test that were different from the other parts of the UK with needing 2 years to fail struggling. Is that, and I think it's implied, is that something that we plan to move on from? Is there a question for that? I was quite surprised by that. My bigger question really is, you know, we look at the stats on these obviously every month around screening, and I'm really impressed with the amount of work you're doing to innovate and try and find ways through it. My question really is, do you think it's enough? Do you think if we achieve what's on those charts, we'll actually get to the state where we're delivering good standards for the people of Wales? That's really the crux of the question.
Thank you. So the newborn hearing screening, it is in line with the UKMC recommendation.
Yeah.
But the practice in England and Scotland is different. So our pathway that they have got is that if it's not 2 ears clear, they will offer audiology. Pathway we have and have had is that if there's 1 ear clear, then actually they're still offered the audiology appointment, but it's just not as explicitly. It's not, and here's your appointment, it's offer. And what's happened when we looked at that data is there's a variation in that uptake, and it's aligned with deprivation. So we're uncomfortable. The pathway's permissive, but it's not as engaged, it's not as focused about the inequities we want to. Wants to move into that, but it's just overwhelming our audiology services in Wales. So that's why we're working really closely with them and have done for some time. So what we're doing is slightly extending this, well, not extending, but we're making the screening path as specific as possible, and then we can work. Then it will not be as overwhelmed as if we kept it as it was and going into audiology. We're working really closely with them around that. So yeah, we want to be moving into that level. And then in terms of will it achieve? So I think it is really challenging. I think we set our standards very challengingly in terms of what we want to, and they're very aspirational in terms of, for example, the assessments. If everybody is in work and no planned leave or unplanned leave, and that, then actually there's sufficient capacity. That's not the reality. That's the problem. So, for example, in West Wales, they're consistently meeting the standard and doing, they've met standard, but they're consistently doing really well. But actually, the team is small. So, if you've got somebody on unplanned leave for a period of time or leave, it affects it. You kind of have to perfectly align everything. So, I think if we wanted it to be more consistent, we'd have to do something different with our staffing. With breast screening and assessment, what we're also looking at, and we want to be part of AI work. So if AI was part of that process, it would take probably, however it would work, it would take up that 1 member of staff. Less visits with people. It wouldn't take everybody out of it, but at the minute we have to have 3 members of staff to do that. So that would be probably the step change in breast screening that we may be able to improve the timeliness of that. So, and the other, you know, it is innovation. So
I just wanted to add on the diabetic eye screening programme. So I think in answer to your question, we're using the demand capacity modelling that we've been undertaking, and I think it's just to use that as a constantly refreshing, revising as we understand what the inputs into that modelling are. So as we get more information about our low risk recall pathway, what impact that's having, what our attendance rates are like, how that then adjusts and our clinic utilisation, how that impacts on our capacity. So we have to the understanding we have at the moment is with the innovations that we're looking at in terms of what the improvement process is and the innovation of the camera technology, our capacity should be meeting what we're currently projected to meet. But that will need to be revised as we get more information. So I think it's using the tools that we've got to be able to inform our understanding, but taking advantage, as Sharon's mentioning, of all the innovative opportunities that as they come along, because we're just seeing that increasing projection of demand, and it's just how we implement the different options that we have available to us to try and adjust that, but keeping an eye on the data in the background and making sure what's going into that model is as accurate as it can be, so that we get the best forecasts and predictions.
That's helpful, but that was kind of what I expected. Part of the worry is that we may never catch up, because you see demand changes and we are learning as we go and we see what does it. So it's part of the question of, do we think it's enough, or will we always be in a catch-up mode? Or if we do think it's enough, do we think we'll meet those targets? I mean, is it 2 years, 4 years, 10 years? But it was partly that, because we look at these and we get concerned about because obviously we have set a high bar and that's great.
Yeah.
But there's a thing, listening to that's kind of what my worry was, is you see these things going and I see them as really good innovation and incremental. Because some of the gaps look really big, so it doesn't make a big enough step change that we ever catch up. Remembering we've got to catch up before we can stay there. And I think what I sense from that is that there is a risk that the volume of work will keep outstripping what we're able to keep up with.
That's not currently what our modelling is telling us in terms of what we're predicting with the innovations we've got planned. I guess what I don't want to say is categorically absolutely, because we're still in the midst of doing the evaluation, and we want to find out what that tells us and what that means, what impact that will have in terms of the proportion of people who will be impacted by that, what that will mean in terms of how we implement in practice, taking into account our staff and changes that they'll have to go through. So the current, I'm optimistic about what that looks like, but then modelling is currently telling us that that's the situation, but we have to adapt, and we have to make sure that we're keeping that.
No, I respect that, and that is helpful. It's helpful to hear that you've got that confidence in it.
Yeah.
And I know it's not an absolute science, but it's good to see what it's based on. It's really good. So thank you. It's great work.
Thanks, Mick. Yeah, thanks both. I know and Graham online as well. It's just kind of unrelenting at the moment, isn't it? Because we're trying to deliver services in a fragile for us, and commissioning services from a very fragile NHS, with population projections heading in the wrong way. I mean, it's a triple whammy, isn't it? So, and I do think it means that we do have to kind of look up and out differently, carry on doing what we're doing, but also looking different, because some of this is about, and I know we're on the journey on, particularly around DESI, for example, around transformation. And DESI, for board members who weren't around during COVID, we were decimated with venues for diabetic eye screening, absolutely decimated, which meant that it took us a couple of years to even get anywhere near, and we still haven't. So that's been a real challenge, because the venues were just reused by local authority colleagues, health board colleagues, understandably, but really challenge the service. So I guess for me, it's what's our future narrative? What is it what's the story that we want to tell the next couple of years? And so there's kind of three areas. There's innovation and technology. There's being brave to try some new stuff out in parallel, with maybe some participant cohorts, or other members of the population. There's looking at what's happening internationally and making sure that we don't want necessarily be the first to try, but certainly if something's proven, why would we not want to look at that across all of our screening programs? So there's an innovation and technology element there, and I don't just mean digital. I mean it needs to be automating. Obviously, I think there's something about getting us to where we need to be anyway, because it's a clinical service. And then I guess it's for us is are there other things that there may not be that we can do around our workforce? Just really conscious. I think the infection service have done an amazing job in the last few years in diversifying their workforce, bringing through individuals who are kind of clinical senior scientists, broadening the clinical governance elements. And I know it's maybe a bit more challenging screening, and I know you're probably thinking about it, but how do we do that? And then the last couple of bits is having sat around the bowel screening Wales, we discussed that in depth earlier for BTW and BSW. But I would say the model in Wales is the most traditional model we've tried as far as, I don't mean us, I mean, no, where are the clinical endoscopists? So what's our role in saying that's not sufficient? And, you know, taking it, there's the service delivery program, and then there's the system leadership program. And I think we probably could be doing more around that. Doesn't mean we're not trying at the moment. And then the final 2 points, I talked about demand. Well, we know what the projections for type 2 diabetes are, all heading in the wrong direction. So we can just draw a line like that, can't we? It doesn't really need that much science. And so if we look at what that means around demand, the model's not working. So what is it that we do with community assets back in the investing enough time to, if Beth and what you're saying around Desu yields what we need, it's probably a point in time. So what is it that allows us to be scalable? And that's where technology comes into my mind. I can't get any beyond that. I don't know what the answers are. Very helpful. The final thing is, we talked about this, Sharon, that Anne mentioned it earlier, the resource base of our screening programs. Historically, we've just got inflation, maybe sometimes. Didn't really get a lot last year, didn't get any last year, in fact. And looking year on year at DESU, looking at our bowel screening, BTW, whilst perhaps the screening participant population remains the same, the detection will be higher. So, and obviously DESU is increasing. So at some point, I'm not saying there's lots of money because we know there isn't, we really do need to do a kind of resource-based allocation that kind of zero-based allocation that says, okay, this is where we're at now. These are the projected demand. This is actually what it's going to cost, because I don't think we've got enough. So I think we need to take that offline and work that through and model it, but be clear on modelling it into what model. So just, I mean, as you can tell, I've got all the answers and talked, but just some reflections.
Yeah. So my point links from both Nick and Tracy's point of views around workforce and what you were saying about we deliver this if we've got everyone in place. Now we had a conversation like this when we talked about the lung cancer case, and in reality you're never going to have everybody, and you've got that added complication of people coming in from health boards to provide services as well. We may have annual leave requirements for them to stay back at the ranch because other surgeons or whatever are on. So I think it's something that maybe we need to think about in terms of right sizing that. You know, in health boards, there's a 26.9% uplift in the nursing establishment to cope with, you know, above beyond annual leave that's profiled in sickness, maternity, etc. So I'm not suggesting we go that in, but I think there's something that we need to think about when we're talking about remodeling this in terms of giving you that headspace. Otherwise, you're constantly going to be playing catch up. I think there's a conversation that both Meng and myself and Claire have also had about outcomes and the impact of some of the delays on maybe some of the outcomes, particularly in breast and bowel, that we probably need to start thinking about just transparently looking at whilst we're in this tricky place with some of the waiting times, particularly in North Wales, and particularly in terms of the colonoscopy waits. And then just finally, probably a little bit more of a question and an offer. Just noticed you picking up in some of the appendices around rework rates, whether rejection rates, or they're all called something different in each programme, aren't they? Rejection rates or inadequate grading or avoidable repeats. And I just wondered, I've just got involved in some of the conversations around CSW and inadequate samples and how they're collected and how they're reported, etc. And it's whether or not we wanted to do a piece of work, because the last thing you want to do is waste capacity or have to do rework. Whether the INI Hub could maybe have a look at that. I know there's small percentages. I don't know what that turns out in terms of numbers of participants, probably greater in diabetic eye than others. So it's just a bit of an offer around maybe how we pull that information through to see whether there's some, you know, improvement work we could do about it. So we have got spaces and capacity. It's absolutely sacrosanct. We don't have to repeat it. We're really happy to help with that.
Yeah, that would be really helpful. You?
Thanks, Claire. Really excited to hear about the developments and the innovation. I want to ask clarification where we are with the newborn blood spots. So are we up to date with the recommendations yet? When will we be implementing it? So we are in the recommendation. So we are providing the same level of checks and screening that providing other parts of the UK. And then my other question is just around, as you mentioned, prostate cancer, because I believe it is the most common cause. type of cancer amongst men in Wales. I think it's about, but I might be wrong. There's about 450 deaths, or that includes 450 or 550. Sorry, I've been lobbied by prostate. I know I'm on the board, unfortunately. So I'm making the case, you can tell them now. You know, it's a big killer, isn't it? And there's not a screening program. So it's understanding where we are on that, because presumably I think it's not age related, but there's a higher incidence amongst older people, and we've got an aging population only. So I presume, you know, we horizon scan, I've got to have more people with PROC. So actually the business case around having a screening program will increase. So question.
So I'll start with prostate, hand over to Sharon to finish up prostate, and the newborn, that's okay. Yeah. So as I kind of alluded to it earlier, the incidence, the detection of prostate cancer in men is common, and it's not, you know, something that actually is the main cause for mortality, right? Men die with prostate cancer rather than of prostate cancer. So it's not surprising the high levels of detection because it's detected somehow, but it's not usually the cause of death. Now, that doesn't mean we shouldn't detect it and offer treatment where treatment's necessary, but one of the issues about treatment is that it does cause complications, and that's always that balance of risk of detection and treatment. So there's a study ongoing called the Transform study that's looking at, I think, 16,000 men, looking at different types of tests that can offer a screening test that is sensitive enough to detect it, but also specific enough to make sure that whoever you're taking through the treatment pathway is going to benefit from it rather than have those adverse complications. Now, we don't essentially look at the science of it within Wales because we are confident that the UK National Screening Committee considers all the evidence. And there's going to be a review coming up, I think next week or so, publishing their latest review of the evidence. So hopefully we will have a position to be able to report back after that publication. But Sharon attends those avidly and is very much involved in that. So maybe there's more update you can.
No, I think you've answered it really well. I think it goes back to what we said at the beginning. It's that population something has to have more benefit than harm.
Yeah.
And that's the worry actually screening is there may be more harm than benefit. Though it's completely really common and completely significant disease, I think the issue. So the UKMSC is considering it. There's a lot in the press around it, as you'll see. And there will be an open consultation on that. It will have all the data and information.
And the blood spot?
So the blood spot, no. So at the minute we so England have gone live with offering tariff, which is recommended, and we're not in a position to offer that in Wales. It makes life really complicated because that population moves across the boundary, so we're having to do quite a bit of work around that. There are two reasons for not doing that currently. One is our digital system. So that is in press. So phase one was making the digital system safe. That happened in the summer. Phase two is now underway, and we need that to physically add more conditions to that IT system. But also the laboratory to a different place. So to make that safe, the laboratory needs to move. They know where they want to be doing, and there's a business case going into Welsh Government in December around that. And once that happens, then those two things mean that we can move to tyrosine. There's a step change with the newborn screening conditions. There are other things where England are doing in-service evaluations, and that's probably with newborn, it's really difficult because the conditions we screen for newborn are usually rare. They're really significant and do massive difference. Makes massive difference to screening the newborns, and you change their life course completely. But they're rare, so it's difficult to gather the evidence. So actually what you have to do is gather the evidence in a safe way in service in that service evaluation. And that's why I think if we get the IT system and we have that laboratory in place, we'll be able to be taking part within these in-service evaluations. Because things like spinal muscular atrophy, that's got treatment for it now, so that needs to look to see whether it's effective, and also severe immunodeficiencies, another issue. But there are other issues that we could be screening for.
So what's the time scale on that? Because it concerns me that we talk about business cases.
Yeah.
Well, we ideally want it in place and moving labs, and that sounds to me like it's several months, not years, and we need to be implementing the recommendations sooner than that.
No, and it's really great for you to say that we're easy to. So we haven't got time scale because we haven't got confirmation of business case yet. But once so and that's the constraint of it. So, but then they are all there for a bit, and that once we got that confirmation, we'll see if we can move. The logistics I understand are there. So we know where the lab is moving. It's just it's not able to do that safely in the confines where it's at.
And are we able to escalate that now? Because I think that there needs to be some pace from Welsh Government about the decision on the business case, because a recommendation's been made, presumably to support the recommendation. So this has to happen. It's not a question about whether it does or doesn't happen. It's a question of when we do it. So understanding better the business case, I think is important, and whether we can accelerate that process.
So the business case, Welsh Government expecting that and asking the lab when it's ready. So they're poised for it. But the Cardiff and Vale lab, it's not our lab. Sorry. Yeah, it's Cardiff and Vale laboratory. I'm putting that with business case, not theirs. But we're joining it together. But thank you for your concern,
But just to follow up, whether it's useful just to reflect this discussion at the next Wales screening committee.
Yeah.
Just to escalate this at that level as well, because that is the place where we take these discussions.
And I'm assuming then that you will keep us up to date with that. There are no more questions. Sharon, thank you very much for whizzing us through that and for answering all of our kind of technical questions as well. And really thanks to the whole team, because we know that the level of service that you're providing to population and the difference it's making to people's lives is, it's almost immeasurable, isn't it? I know we're looking at numbers, but what I'm trying to say is this is making such a difference to people's lives every day. So I think really just a huge thank you to you and the team and for taking us through this as well. And your work with the health boards as well in order to make the difference to people's lives going forward. So thank you very much for that.
Thank you. Thanks all.
Thank you.
Thanks, Freya. Thank you.
We're going to move on to the next item on the agenda. I'm sorry that we take some courage on that presentation that we've just had. And the next item on the agenda is the reports from the committees of the board. We've had Knowledge, Research and Information Committee. We've had all of the committees that have taken place since the last board meeting. So I'm just going to check with the chairs. Sean, was there anything you wanted to highlight at all, or are you happy with?
No, I was happy with the report. Okay.
Claire?
Only to say we had a really interesting meeting on Monday just gone that isn't obviously written yet into the papers. Took assurance on a range of things, infection prevention control. It was a very good meeting, took assurance around that. But obviously nothing that's urgent, so we could catch up for the next week.
Okay, great, thank you. Kate, was there anything from you?
No, just I was just in the hot seat for the first time, so yeah, I'm trying to be some good notes for me.
And Tamsin, anything that isn't covered in this report from you? No, that's great. Lovely, thank you very much. So we can take those items. We need to approve the minutes on the action log from the September board meeting. Are there any comments, anything? Everybody happy with the minutes? Yes, anything on the action log that we need to note or approve, or questions around the action log? No. Quite great. Claire, then I'm going to go to you if you can just give us the updated strategic risk register.
Yeah, conscious of the time. So fortunately this month you'll see in your pack the risk at a glance paper. It's a piece of work that we're working on for people's request, just to give the new board members, but also at a glance so people can have a look at what's the worry list, what's doing okay, and any particular changes. So we'll continue to refine that. And certainly some feedback from QSIC the other day from Nick was that actually it'd be really useful to see what the tolerance of risk appetite is in numbers so that we can remind ourselves, because the report has changed a little bit. So SRR1, led by Jim, overseen by QSIC, currently a score of 9, intolerance, and we hope to do a deep dive into strategic risk 1 at our next meeting on the 10th of November, or as soon as we can. So we've already started to do that preparatory work, but no significant change. But this is the risk that we know we had to rewrite earlier in the year. So we're really comfortable with the architecture in there at the moment. We just need to know whether we can move some of our DAPs to controls now, given the work that's happened in that space. And then just to add, we had the really good meeting with WCVA yesterday, so that will get reflected in the updated position as well. Anything specific from you, Jim?
No, I think you covered that very well. You can take the final one.
SRR2 is led by Neil, again with intolerance level at the level of 9, no change in the score, overseen by Podcom. We've strengthened that risk based on feedback from Ian. Ian was particularly worried about capacity and capability in the workforce. So that's been added and will be seen in the red in the update there. So I think particularly extra for adding into that one. SRR3, which is overseen by Meng and supported by myself, overseen by QSIC. Currently at 12, which is with intolerant. I have had a very brief email with Meng to say that I think we need to just revisit that score based on some of the conversations that we've had today in terms of likelihood. Because at the moment that's saying it's a 3, it's whether, so we need to have a conversation around whether that needs to increase, given that we know there is likelihood in some of the screening programs, but not all of Meng's services. So it's part of it that we need to discuss. And is there anything else you wanted to pick up on?
Yeah, I think it's worth reflecting that when this was filled in, it was.
Yeah, absolutely. Yeah, great.
So
yeah,
it's always going to be a challenging position, and it's not an exact science. I think some of the trends are suggesting that we might reflect a higher likelihood scope.
So this is the October position, as you say, then things have changed since then. That does take us outside of our tolerance, our appetite, so we would need to completely understand what the new actions would be in there to bring us back into line. SRR4, overseen by Crick. This is one of our newer ones, and I think is probably one of the most robust because it's got lots of new evidence in there. It's got lots of new actions, and it's obviously supported by the work and the committee that the change board that Samina attends and updates on our behalf. Anything specific you wanted to pick up there, Samina? Quite a lot of novel changes going in depending on each change board. Yeah.
Thank you, Claire. So Meng and I both co-chair, and there's a bit of a lag. So the last meeting was in November. We have looked at the risk score. We will drop the likelihood of the risk, and there are a few more actions that we were looking to add. And also the structure of the Climate Change Programme Board is likely to change pending final agreement. So I think, yeah, we're strengthening it.
And then last but not least is SRR5, which is overseen by Ian, again under the leadership of Crick, and very much links to our capacity and capability, so links to strategic risk 2. We're just continuing to build on that one. That's moving in the right direction, but we just need to continue to build in terms of the controls assurance on that. So I don't know whether you wanted to add anything extra here in that space.
No, just to say we're actively managing it, particularly through the IMTP, recognising how full the digital agenda is and the need to make sure that we don't overstretch by taking on too much at once.
Lovely, thank you, Claire. And obviously we've got the full risk register attached, but just a personal thank you from me on the risks on page. Very clear, gives us a really good kind of snapshot of where we are with everything. So I really appreciate that. Are there any questions around the risk register from anybody? No? I think
that's the first time.
Yeah, and I think it's because you put so much work into what it looks like now, how it reads, and how understandable it is. You'll get less questions because it's all there ready for us to read. So big thanks to you and the team for putting all the work into that. And are people happy to approve the risk register as it is, noting of course that some things are going to change? And that's and from my perspective as well, I think the board can really take assurance of the fact that you're having the discussion whether you should change risks based on current circumstances. So I think it's really good for us to hear. Is there anything else on this matter? No. Okay, so I think we are into the last items on the agenda. There's a number of items to note. The chair's report from the last private board, board forward plan, and the vaping position statement as well is included there. Is there anything anybody wanted to say on that, Ben?
Just to clarify, and the papers are frozen for me, but at the private board, we mentioned the business justification in case for capital for lung cancer. Just to clarify, we've submitted the case for capital and revenue because there have been adjustments.
Oh, that's really helpful, thank you. Okay, I am aware that we've overrun, and so I'll get the meeting closed if we can, unless there is any other business from anybody. I'm not seeing any other business. Our next meeting is in January 29. Thank you very much, everybody, for attending today. Thank you.